Thank you for joining up. Welcome to another segment or episode of our acute physio essential. So today is going to be on traumatic brain injury. So before we start, of course, I like to hear our about our experience about managing patients with traumatic brain injury and how they are quite different from other neuro conditions that we see on our day-to-day world or on our day-to-day work settings. Am I audible enough, sir?
Sorry.
Hello? Hello?
Yes, we are hearing you, sir.
Oh, okay. Thank you. I just have to double check because so like I said, it's gonna be on TBI today, and hopefully we're gonna have a nice time, and it's gonna be discussion throughout. But to start off, I'd like to hear our experiences about how we manage patients with TBI and how they are quite different from other neuro conditions like stroke or somebody that's got spinal cord injury or somebody with cancer myelitis or any other neuro conditions. How is TBI quite, how are they quite, their management of TBI, how is it quite different from other neuro conditions? I think it's first things I really want us to talk about. Okay, thank you. It's Anthony. Can anyone just share his or her experience about TBI patient they've seen in the past, what they did for them, how that management was quite different from handling a stroke patient? Can anyone share their experience? Because one thing about clinical discussions like we're having is just you sharing your experience, me sharing my experience, so that we can all learn from each other. Yeah. Anyone here to share their experience about TBI they've seen in the past and how that is quite different, for instance, from a stroke patient, how their management is quite different? Anyone? Feel free to open your mic, or you pop your response in the chat box. Let's start this way so we can have a clear picture of what we are here to discuss today. Hello, is anyone there? Anyone ready to share their experience? Okay. So I crack on with the presentations, but if you really want to share your experience, just pop that in the chat box and we can review together. So, all right, let's continue. I think the first thing that's worth talking about is how would define TBI generally or traumatic brain injury. There are a lot of definitions out there, which I think, yeah, there are a lot of them, loads and loads of them, but some brief ones I really want us to look into. The first one here says TBI is just physiological disruptions to brain by any biomechanical forces, any external forces that could cause any rapid acceleration or deceleration to the brain. What are all these terminologies? What do they really mean? That's why I actually popped this definition here, just to talk about the terminology here. So what do they really mean? Generally speaking, there are a lot of forces that can actually make somebody to have a TBI. It could even be beyond mechanical forces. It could be radiations. It could be chemical related. It could be anything related. But the common type, we can all. I think somebody is. Can you mute yourself? It is part. All right. Thank you. So, like I was saying, there are a lot of forces that can actually impact the brain, but the commonest forces we all know is the mechanical forces. And so again, so if you remember our physics from secondary school, we all know that if a force is exerted on an object, for instance, let's say this is an object, if I blast this object with a force, of course, the level of exertion of that force will be dependent on the mass, the size of the object I'm hitting on this bottle, and also the speed in which I'm hitting these things. All these things will also be linked directly with TBI as well. So the impact of the impact of injury on the patient will be directly related with the size of the object the patient hit their head on, or their object is being hit on their head or something like that. And again, the speed at which they blast their head or on any surface, or the speed at which any object is being blasted on their head. All of these things can also be directly linked with the severity and the level of injury that the patient will actually come up with. And again, we all know when it comes to mechanisms, it could be blunt, it could be penetrating injuries. We're going to talk about those things in a minute. And again, generally speaking, I think we all know when it comes to the rate by which a male patient or male individual can come up with this injury are far very high compared to female. There are a lot of course, we can all relate that. You find males doing a lot of very high risk behavior activities. You find males climbing four-story buildings with a ladder. You find males climbing electric poles. You find males doing some reckless drivings on the street. You find males drinking to the level of stupors and still driving and all of those things. So we can all relate to that. They are directly related. So so let's continue. So when it comes to the causes of TBI, I want us to pop some ideas in the chat box as well. So so what do we think are the causes of TBI? Can I get some ideas in the chat box? I want these things to really be I want it to be a discussion. Can I get some idea in the chat box? What are the causes of TBI? Yeah. Okay. Please, can you pop some yeah? Good evening, yeah. Yeah, falls. Thank you, Peter Stella. You can have a patient with fall, yeah, either high velocity or low velocity, like you can find in node dot, for instance, yeah, you can find that. Yeah, gunshot, yeah, thank you very much. Gunshot to the head, that may cause penetrating injury, accidents, road traffic accident, collisions, yeah. Those are nice examples. Can we have much? Yeah, drowning, yeah, great job. Thank you very much, Peter Stella. Additional, you can find patient with road traffic accident. Yeah, great. Yeah, great. Yeah, tumor. Yeah, great. Yeah, great. You can find somebody with a tumor. You can find, yeah. Sol is also another one. Thank you. Yeah, road traffic accident. Yeah, can we have more? Can we have more other causes of road traffic accident? Beyond tumor, beyond road traffic collision or accident, beyond stabbing injuries. Can we have more? Yeah, can we have more? Yeah, that is traumatic related. There are a lot of reasons for brain injury, yeah, but traumatic related now, yeah. How about people in sports? You can have sport injuries, yeah. You have people playing some rugby, even football. We can find people with traumatic injuries. So we won't waste time on that. These are familiar things, and of course, in all of these causes, you can have some of them that are penetrating injuries, you can have some of them that are blunt injuries. And if you also look into the mechanism, if you go back to, please, if you go back to the definition I said earlier, you can define some terminologies like accelerations, decelerations. What are those things? What do they mean? Acceleration is just, for instance, suppose this is, suppose okay, no, let me use this. Suppose acceleration injury is just when you've got a moving object that is impacting on the patient's head. That's just acceleration injury. You can have deceleration, like your patient head is being exerted on the stationary object. Your patient head is the moving object now, like is the one in motion now. Let's say, for instance, now somebody is falling from a height of maybe they are climbing a ladder, something like that. So they are falling from that height now. So the floor is the stationary object. Their head is going to be the moving object. If that makes sense. So you can have all of these things. So you can also, there are a lot of mechanisms. You can find rotations, like there is a movement of the head in the skull. You can find compressions and all of those things. But what is really important to us, we are going there. So for anatomy, let's talk about anatomy. Of course, there are a lot of anatomy related with brain injury as well. I'll try as much as possible to simplify some relevant areas that we need to remember. I think the first area we need to remember here is that the meninges of the brain cover. We need to remember this because when it comes to brain bleed, patient can bleed to different areas of their brain, and the terminologies, the way these things are being said, they are said in reference to the brain cover. So we need to remember this. Of course, remember your dura mater. There are three coverings of the brain. We've got the dura mater, which is the outer part. We have the arachnoid and the middle part, and the innermost layer is the pia mater. You can see from this. So, and again, we need to be aware, if you look at the space between the arachnoid layer and the pia mater here, you can find your arachnoid space. This is where you find your CSF fluids. Yeah, that's really very important to remember. Of course, CSF also have relation with your ventricles and other parts of the brain as well. So try to remember this, the dura mater, the arachnoid, and the pia mater as well are very important. So just leave this. So again, some other areas of the anatomy you need to remember is, generally speaking, remember, of course, remember your brain, your skull. We all know that the skull is a rigid bone, and this is a bone that cannot be expanded. It cannot be, it cannot be expanded. It's a rigid bone. So inside this bone, there are three structures in our head. You've got your CSF, you've got your brain cells, and you. Please, Peter Mohammed, please. Can you mute yourself? Peter Mohammed, please. Yeah. So in the brain, like I was saying, you've got three components in the brain. You've got your CSF, you've got your brain cells, and you've got your blood volume. Of course, your blood volume contains your arteries and the brain. Why is this thing related? Let's go there. So there is a concept called Morokeli doctrine. So I'm going to use this to explain some concept related with the brain. Hello, are we still there, please? Hello, are we following? Is it making sense? Hello?
Yes, sir. We are with you, sir.
All right, thank you. Can I get more response just to double check? Yeah. Is it making sense to us?
Yes, sir.
Yes, sir.
Right,
It's a lot of sense.
All right, thank you very much, sir. Thank you, everyone. So there is a concept called Morokeli doctrines. I don't know if we've heard of this thing before. So what this concept talks about is, suppose this is a brain. So inside this brain, you've got three structures inside your cranial cavity. You've got the brain, you've got the CSF, and you've got the blood volume, the arteries and the veins inside the brain. So what this concept says is, of course, we have mentioned that the brain cavity cannot be expanded. If there is any change in any of these three structures, please, Peter Mohammed, please, can you mute yourself, please? Thank you. Time is going. We have important things to discuss. Peter Mohammed, please. How can we mute you? All right. So like I was saying, remember your skull inside the brain volume we've got has three things, three domains. We've got the brain cell, we've got the CSF, and we've got the blood volume. So if there is a change in any of these three, what happens is, for instance, if there is an increase in, let's say there's an increase in the volume of the brain.
Please, can the admin mute these people?
So if there is any change in any of these three, what happens in the long run is one or the other two is going to try to compensate for the changes that happen. Don't let me make it abstract. Let me try and go to my next slide to explain these things, make it more interesting. I'll come back to this one. This is what I'm saying. There are three structures. We've got three structures in our head. We've got the volume, the blood volume. We've got these blood cells, and we've got the ICF. So if there is any change, let's say for instance, now somebody have got a brain bleed, they've sustained head injury, so they are bleeding into their subarachnoid space, or they are bleeding into anywhere in the brain. So what is going to happen is, if you look at this picture here, now this picture is saying there is a mass in their brain. The mass could be anything, it could be edema, it could be tumor, it could be anything in their brain. So there will be compensations from the other two. Now the other two, normally, your CSF will try to compensate. How does CSF compensate? The CSF will start, your body, the CSF will start draining to the venous system and start coming out of your brain. So that the size that your CSF occupies will start getting smaller. That is what we are saying, in order to compensate for that effect. Because the brain cannot expand. The skull cannot expand. So now there is a new mass in the brain. There is now new thing occupying the space in the brain. So something needs to be decreased in order for that new mass to be able to establish themselves in the brain, if that makes sense. So now, if you look at this structure here, so somebody have got, if you look at the first one here, normal ICP, normal brain functioning, the CSF is draining normally, the venous system, they are operating normally, they are steady and flowing. And remember, one thing we also need to remember here is these structures in this brain, they are in a state of dynamic equilibrium. They are in a state of dynamic equilibrium. They are just operating normally, nice and steady, no concern. But if somebody have got brain injury, they've got bleeding, they've got tumor, they've got anything now impacting on their brain, there's now new things in the brain. So increase in any of those things, if there is increase in volume, if there is increase in, if there is a new mark, let's say tumor in the brain. So other two domains, they will need to get decreased in order to accommodate that new change in the brain, because the skull on its own cannot expand, if that makes sense. If you look at this picture here, if you look at this now, so what happened here? The CSF start draining, the venous volume also start draining, they are coming to the jugular, they are going into the, they are going back to the heart in order to accommodate this mass. That is what that is. So now, if you look at this now, see on this picture. So why is this compensations happening for people that have brain injury? Why is that compensation happening? The compensation is happening in order for the brain to maintain that normal pressure. That normal pressure that the brain is meant to be exerted on the skull, on the bones, on the skull bone. Now, at some point, let's say, for instance, now your patient has got a brain bleed, they are bleeding into any space in their brain, something like that. The volume of that bleed is not getting much and much. What will happen? Compensation will first happen. Your CSF will start draining, your venous system will start draining in order to accommodate that new thing. But at some point, if that thing is getting much and much, what is going to happen is the compensation will fail. If the compensation fails, what is going to happen in the long run? The ICF, the pressure in the brain, the pressure in which the brain is being exerted on the skull will start getting more. If that ICP, intracranial pressure, that start getting more, what is going to happen? Brain can start herniating down, of course, your brain tissue will start compressing, and they can start coming down into the spinal cord through that foramen magnum, something like that. So, so this is also very important, and we need to always remember this concept of Morrow-Kelly doctrines. It is really, really very important in managing patients with acute traumatic brain injury. And because in all of these things, one thing you are supposed to remember as a clinician is their ICP. When you go to their bedside, always remember ICP, intracranial pressure. Because if the intracranial pressure extremely go high than expected, what is going to happen? The brain cells will start compressing. There will be more ischemic damage to the brain, and again, the patient can even die. Brain tissue can start compressing. The happening centers in the brainstem can start compressing, and the patient will die. And there can even be alienations of their brain into the spinal cord, which is not supposed to be. So this is really, really very important concept for everyone to remember. And again, like I mentioned, though any of those three things can be increased, like a brain now, for instance, there can be edema in the brain, there can be tumor in the brain. These are things that can likely things that can make the volume that the brain occupies. Normally, the brain occupies about 80%. Of course, the brain cell occupies by 80% is the largest content we've got in our skull. So if somebody have got tumor can make that can make that cell, can make that space, the space that the brain occupies to be more to be more it can make the brain to occupy more space than expected. Now CSF, again, if somebody have got, for instance, somebody have got hydrocephalus, for instance, now somebody have got hydrocephalus, what will happen? There is a lot of fluid around the brain will start getting wet and all of those things. And again, the volume that the CSF now occupies in the space are supposed to be, normally the CSF supposed to occupy 10%, something like that. So if somebody have got hydrocephalus, what is going to happen? The volume of that CSF will be much more than expected. And again, that can also increase the intracranial pressure. The other part, they will start to regulate that. They will start to do some compensation because the skull itself cannot expand. It cannot expand, especially in adults. So again, cerebral volume, the blood volume can also, can also impact that. For instance, somebody have got brain bleed like hematoma, somebody have got subarachnoid hemorrhage, or somebody have got vasodilations, anything that is dilating their heart, that is dilating their blood vessels, their arteries. For instance, if there is increase in CO2, I'm going to talk about that very soon because we need to know these things in acute management of TBI patients. If you don't know all these things, honestly, you cannot effectively manage it, especially those ones that are acutely unwell. You cannot manage them effectively. So let's spend some time on these things. It's really very important. We know all of these things. Vasodilations might be, let's say there are some medications that can abnormally vasodilate their arteries, their cerebral arteries, or maybe they've got increase in CO2, for instance. Increase in CO2 can also vasodilate their cerebral arteries, can make more perfusions to the brain. Great. Well, if somebody has got brain injury, we want their brain to be more perfused, but not with high pressure. If the blood is flowing to the brain too much, what is going to happen? The volume that the blood is occupying in the brain will be more than expected. And again, in the long run, if the compensatory mechanism fails, the intracranial pressure will start going up. And what can happen? Death can resolve, alienations can resolve, and all of those things. Does this thing make sense, please, guys? Are we still there? Is it making sense? Does this concept need to be understood?
Yes.
All right.
Yes.
Thank you very much. Yeah. So we move away. This picture here is just showing normal thing. If you look at the first one here, you have two things compensating for normally work, like if they are working well, they should be compensating well. Like you have the brain system draining, you have the CSF flowing nice and okay in the brain, providing some shock absorbing and all of those things. But if somebody have got like increased mass, like I said, these two systems will kick in. They will start compensating and compensating. Yeah. And again, if that mass is getting more like it's getting bigger and bigger, what is going to happen at some point? That compensation will fail. And if that fails, we all know what can happen from my explanation. Let's remember all of these things. We are managing patients with acute brain injury. They are really, really very important. So, like I mentioned, ICP is really very important to us as physio. It's not about knowing big anatomy, big names, and all of those things that do not relate to patient care. It's about knowing anatomy that is relevant to your patient care, administer your treatment, and be able to monitor some certain parameters. That is what really, really matters. And that is why I have just limited to anatomy that are very, very important to us. So remember your ICP, like I mentioned, generally speaking, in a normal person, normal adult, we want ICP to be as something low, like as low as less than 10, something like that, less than 15. But In somebody with brain injury, they've got TB high, ICP, like, we still want it to be maybe something less than 20. Like, we give them that space because we know there will be compensations. The pressure, the normal pressure that the brain is being exerted on the bones, on the skull, we know that will change. We know that if somebody have got brain injury. But still with that, we still want the ICP to be something like less than 20, less than 25. Yeah, but these things is not decided by physio. This thing will be decided by your medical team. These things will be decided. So if you are reading the medical note, these are some of those things you want to acute patients that are acutely unwell. You are seeing them in acute hospital. So you want to pay you want to try and check what is the target ICP range. If you're not just checking notes, you pay attention to ICP because any of your physio techniques has direct impact on the ICP. Anything you want to do for this patient can worsen the ICP. And if you know, if the ICP from my previous explanation, if the ICP suddenly becomes worsened, what is going to happen? Their brain can start compressing. Their brain tissue can start herniating down. You don't want all of these things to happen. So that is really very important for us. I think I forgot for people that love visual things, I forgot to talk about this graph here. So what this graph shows here is, I won't go through the score bones I've put here because of time. So what this graph shows is, initially, there is a compensation, but at some point, there is decompensation. The compensatory mechanism fails, and the ICP start going up, maybe around 120, 110 volume or something like that. Then the ICP start going up. That's what that means. So just have a picture, just have this picture in your head. You are going to the bedside to treat an acutely unwell, new traumatic brain injury patient. You are looking into the notes, you are trying to find out what is the target range for ICP. If they've not written that in the note, you want to ask them, you want to speak to them. You want to let them understand why that is very important to you as physio. Because whatever you be doing with that patient acutely, that will impact on the ICP, if that makes sense. So let's move forward. And again, there are signs and symptoms we need to be paying attention to as physio. You go to their bedside. Normally, if you are very keen, if you've seen load of these patients, you can testify to this. Most of them will complain of headaches, vomiting, nausea, all those things. Yeah. And again, their GCS is also something we need to their level of consciousness, we need to keep paying attention to that. And we, as physio, we need to be able to score those things accurately. I'm not going to talk about GCS in these presentations. I think I've had that in the past. Go over those things. It's one of those things we need to be able to do as an acute physio, scoring it well and escalating, because it could be you. It could be maybe you've gone to their bedside now. It could be you at their bedside and their GCS is just dropping and dropping. What do you want to do? You need to be able to pick up something and escalate immediately. Escalate immediately, because patient can rapidly deteriorate. This patient can rapidly deteriorate. So this is really very important to us. You can find a lot of clinical signs you can pick up. Pupillary dilations. There's something we call Cousin triad. It's something we need to be able to we need to be aware of as physio as well. You go to patient bedside, their systolic blood pressure is just too high, and they are bradycardic. And again, you find their pupillar response is not okay. Have you spoken to the medical team? All of these things might be a sign that their cranial pressure is getting worse. It's just jumping up. It's started getting higher and higher. So you need to speak to somebody. You might need medical intervention at that moment. So these are really very important for us when it comes to some of these patients. So yeah, again, another reason behind, aside from brain herniation than the foramen magnum or delt or anything, another thing acutely that we also need to be aware of as physio, when you go to the bedside, of course, especially for people that are on monitoring like ICP boats or something like that, I'm going to throw some of these things. So you also need to monitor, if you are doing treatment, not just ICP, you're also monitoring their CPP, cerebral perfusion pressure. So what that means is, so the CPP is just, for instance, now, if there is any compromise to cerebral perfusion pressure, is just the pressure at which the brain is getting food. They are getting oxygen, they are getting nutrition. Don't let us bring a lot of jargon on table here. Let's say what is relevant and what we need to know as physio. So it's just think about CPP as, oh yeah, the pressure that will bring blood, that will bring oxygen, that will bring food to the brain. So if there is any compromise to the CPP, If somebody has got acute brain injury that is compromised to the CPP, what is going to happen? The brain is not going to get food. If they are getting starved, what is going to happen? They will start dying. Ischemia, tissue, brain death, all of those things will start happening. It's not something we want. It's not something we want for them. All right. So, and again, if you look at this equation here, so your cerebral perfusion pressure is equivalent to your MAP minus intracranial pressure. So that means, let's say for instance now, somebody has, if intracranial pressure is directly or indirectly linked with your CPP. That's what we are saying. Yeah. If intracranial pressure is higher than expected, what is going to happen to cerebral perfusion pressure? The brain tissue, even before the, now, if the pressure in the brain is too much, what is going to happen to the blood vessels? It's going to compress the blood vessels. The blood vessels will not be able to bring nutrition, bring blood, bring oxygen, and whatever to the brain. So the brain tissue will start dying. So if there is increase in ICP, that is going to drop your CPP. If that makes sense to somebody. Remember these things. You go to patient bedside, they are on ICP, they are on EBD or whatever thing they are on. Ideally, they should be on big screen. They should have a big screen at their bedside. You want to be monitoring their ICP, not only ICP. You know, ICP is linked to CPP. Great. You are also monitoring their CPP, because you know if CPP drops below expected, again, even without intracranial pressure going high, CPP can also drop on its own. It could be, let's say for instance, now this is another concept on MAP, mean arterial pressure. If mean arterial pressure is not optimal here, this can also impact the CPP of this patient. So these are things you are checking at their bedside. You are checking the ICP, you are checking the CPP, and you're also looking at their MAP. You are looking at their mean arterial pressure. You know, mean arterial pressure is, for instance, let's say if you are taking the blood pressure of somebody now, you will find something like, let's say 120 by 160, systolic, diastolic. You find that thing in the bracket. That is the mean arterial pressure. That is their mean arterial pressure, something like that. So pay attention to all of these things. So generally, again, if you are reading the medical note, you are looking at their notes, their surgical procedure they've had, anything they've had, their medical journey, and what they've done, the medical team have done for them in the hospital. You are paying attention to the ICP. You are looking at what is the target range for ICP, what is the target range for CPP, what is the mean arterial pressure. All these things are meant to be done. We don't set them. The medical team, the neurosurgeons, the neuro team will be the ones to set all of these targets, and you are supposed to work with them as physio as well. Because like I mentioned again, whatever things you'll be going to do, the best side of this patient, if you are not checking all of these things, it's either you are not doing much for your patient when you are supposed to be doing much, or it's either you are doing something that is endangering the life of your patient. Think about this thing. So we really need to be aware of some of these monitoring device and monitoring target range when you go to their bedside. Check whatever they've written in the medical note. If they've not documented this, demonstrate level of knowledge and demonstrate how these things are directly linked to physio. If that makes sense. Hello? Hello, are we still there? Hello, are we still there, please?
Yes, sir, we are there.
Yes, we are there.
Right, thank you very much. Thank you very much. And are we getting the concept as well? Because this thing is really very important. Are we getting those concepts? Sir?
Yes.
All right, thank you very much. So that is that about that. So I'll come back to partial pressure of CO2. I will explain how that is being linked with all of these things, but let's continue on this lane for so that's that. So I'll come back to this slide later. So generally speaking, you might find maybe the MAP, maybe the mean arterial pressure. Generally speaking, they might say, okay, keep it less than 80. They might say that, no, they might also set the cerebral perfusion pressure as well. You find the target there. They will set the ICP. They might say ICP less than 20, something like that. Work with whatever they've written. And if you have any concern on any of those things, then you can speak to them. But it is really important you look for those things in your medical note. It's very, really, very, if they are not documenting it, get them to document it for you. It's very important. All right. So let's talk about classification of TB high. Of course, we can have pathophysiology classifications. You can have the primary injuries and secondary injuries. Primary injury is just injury that happens because of the impact, because of the force of exertion that happens to the brain. That's primary injury. Secondary injury is just the associated injuries from primary injury, the cascade of reaction that happens following the primary injury. That's just the secondary injury, like the biochemical changes that happens. Let's say, for instance, now somebody have got brain injury. With time, they are bleeding too much into their brain. So what will happen is that can start compressing on their brain, all of those things. Yeah, that may result in secondary injury. If that makes sense to somebody, that might cause secondary injury. Or it could even be maybe systemic issues, like maybe their glucose is not optimal or their HB is dangerously low. At the point of their accident, they've lost too much of blood. Now there is little oxygen going into their brain. That may cause secondary injury. Those are secondary injury, if that makes sense. So, and so let me just go this way. So, like I said, primary injuries it could be compressions, it could be shearing force, it could be stretching, it could be this thing we call cool. I think I've got it. Cool and counter cool. Cool is just, you can see the picture here, like bouncing and rebouncing kind of injury. You can find it here. I'm not going to waste time on all these things. I want to pass. Yeah, I know we know all of these things. I'm not going to waste time here. So so that's that about that. So some other things is you can have vocal injury as well. You can have you can have focal injuries. Focal injuries can be epidural hematoma. Epidural is just injury between your skull and the dura mater. So generally speaking, I think later on we can have discussion about CT scan, like what we need to know from physio perspective, MRI, what we need to know from physio perspective, and so that's why I've not put enough CT or MRI into all of these things, but we can have that discussion separately so that that will not take us from how we can manage acute TBI patient. We can have that because there are some basic things we need to be able to recognize on this scan as physio. Yeah. So, but for now, just remember this is just CT scan, for instance. Now, epidural, you can find this lemon shape structure. If you just look at this, you can find that here. So subdural is just you are bleeding between your between the dura mater and the arachnoid layer. That's where you are bleeding. So, and with that one, you might find these banana kind of things on the scan. Don't worry about that. We can have a separate discussion about diagnostic tools later on. Subarachnoid is just you bleeding between your pia maters and the between the pia maters and the arachnoid layer. So that's that about that. So so again, yeah, physio-wise, what do we have to remember about these things? So what I normally remember is if somebody have got epidural hematoma, I remember, this might be arterial related. Maybe they are breathing, they are what do you call it again? Their meningeal arteries are being impacted, something like that. This is what I remember. I'm telling you what I remember on these things. Yeah, their middle cerebral, their meningeal artery has been impacted, which means that artery. Remember your artery. Artery is a high pressure system. High pressure system generally in the body compared to veins in the body, right? So that means if care is not taken, if medical treatment or any treatment that needs to be done are not done immediately, what can happen? This patient can continue to bleed and bleed. Remember that Morrow-Kelly doctrine that we spoke about. If they continue to bleed and bleed and bleed and bleed, what is going to happen? That volume, remember you've got 3 components in your brain. Now, what is going to happen? That edema will keep getting bigger and bigger. What is going to happen? There will be compensation. At some point, compensation will fail. What can happen? Patient can die. Anything can happen. Brain lamination can happen. So I remember that yeah, this patient needs medical treatment, urgent medical treatment. Remember that, really important. Yeah, and usually you might find maybe injury to be temporal lobe or something like that. Yeah, it's something you can also remember. I just remember things that are quite related to it. And again, when it comes to deterioration, sometimes some people might have even stabilized some people, because sometimes you might find these people maybe at some point they are they've not got any level of consciousness, like they've lost consciousness. You go to their best at some point they start waking up, and again they can suddenly deteriorate again. You can find, if you've managed some of these TBI patients, you can find this trend in some of them. So you need to be aware. You've seen in the medical note, oh yeah, this patient, they've got this kind of epidural hematoma or extradural, whatever you want to call it, hematoma. Yeah, I go to their bedside. I remember, yeah, this is arterial bleeding. They are bleeding with the artery. This is arterial bleeding. I know that, yeah, I have to be cautious when it comes to my physio interventions with them. I don't want to do things that can increase their intracranial pressure, that can cause more compression for them, that can. So I think in that way. So I go take good attention. When I'm doing my treatment with them, I'm looking at my ICP, I'm paying attention to my CPP, I'm paying attention to my mean arterial pressure. If that makes sense to somebody, just correlate whatever you know anatomically and correlate it with what matters to patients. We can tell ourselves thousands of things here, but if those things are not linked to patients, those knowledge are useless. So let's tell ourselves what are very, very linked to patient care. Now, if you look at subdural hematoma, what do I remember generally? I remember subdural might be something related with veins, cortical bridging veins, something like that, yeah? And usually, and again, you might find patient, maybe they might be stable, maybe one first day, second day, and at some point they start deteriorating. Because when it comes to venous system are like, what do you call it? Their venous system are, when it comes to pressure, they have less pressure compared to artery. It can just be maybe just remember, like just like if I open a tap now and water just starts dripping down, something like that. It might be their bleeding might be like that in their brain. Maybe it's just dropping down. It might take a long time before you see that big deterioration in them. Just think about those things if you are in their bedside. These are what you should be remembered physically when you are at their bedside, if that makes sense. So all right, so you can find open injury, you can find diffuse injury. Diffuse injury is also another very terrible injury. Maybe I just show you that on this CT scan. This is just intracranial. Intracranial is just focal injury, localized injury to one lobe. And again, with that one as well, if let's say there's a bleeding around this area, what can happen in the long run is there might be compression. This can start shifting other lobes, other areas of the brain to one side, if that makes sense. This is diffuse axonal injury. What happened? Forget about name. I don't want to start come here now and talk you through about Sokai, ventricle, and forget about those things for now. We can have a separate discussion about these things and talk it through ourselves. What is really, really relevant, we need to remember as physio in all of these things. But what I really want you to remember here is, if you look at this CT scan, of course, this is normal, and this is the abnormal one here. You can see here, you can see some Sokai, you can see ventricular region. Sorry, you can see some region here. You can see the gray, you can see this region here are clearly partitioned. But if you look at this one here, what happened? Everywhere is just looking like the same thing. Yeah. So this is what you find in diffuse injury. And again, remember, we said here that somebody can have diffuse and somebody can have focal. The fact that somebody can have, we said it is focal. Let's say they've written a medical note that, oh, they have a focal injury. That does not make it less compared to diffuse. Somebody that have focal injury can also, focal is just localized, maybe localized to one part, let's say to the frontal lobe now, for instance. That does not make it less evil. If you know what I mean, just remember what really matters and to your patient care. That focal does not make it less evil. Because remember, with bleeding, if they continue to bleed, if we are not taking good care of them, there is no good medical intervention with them, what is going to happen with time? What is going to happen is their brain volume start going wider and wider. That can also compress other structures of the brain, and it can also result in death. So the fact that they are focal, it is not diffuse, does not make it a less evil. If you understand what I'm trying to pass across. Yeah. So that's that about that. Secondary, like I mentioned, secondary is just, cascade of events following the primary injury. It could be maybe there is swelling, there is hematoma, there is reduced oxygen to the brain. It could be maybe now they have fever. If somebody has got fever, for instance, let's say somebody have got TBI injury now, and now they've got chest infection or any infection, now their temperature is really going high. That is going to increase their metabolic demand in their brain. For every 1 degree temperature rise, for every 1 degree, there is a kind of, I think 5 degree needs 5% of, I think, is it 5 degree or 5% needs in oxygen demand in their brain. And don't forget, what we want in somebody that have got recent or acute brain injuries, we want good perfusion, we want good blood flow to their brain. we don't want abnormal. We don't want the blood flow to be too much, because if the blood flow is too much, what is going to happen is the volume will be much and more compression. So we don't want them to lose other area that are intact. We don't want them to lose the other functioning parts, other structures of the brain that are intact. So we want that nice blood supply to those other areas. So now, if somebody has got fever, or they've got infection, or there is rise in their temperature in their body, what is going to happen is that will increase the metabolic demand of oxygen in their brain, which is something that can further damage our brain. So generally, what you find with patients with TBI is they try to keep the temperature low. As physio, you need to know these things. You really need to know this, because it could be you go to their bedside and you find them, they might even be shaking, their temperatures. You have to speak with the medical team. They try to keep their temperature low, or they keep it normal, but they don't want that hypothermia. They don't want that high temperature. And again, if you are documenting your note, these are stuff you want to be seeing in your note. These are stuff you need to make your own clinical reasoning as well. All these things are really, really very important. So these are acute care for TBI. So we have to be aware of all of these things. So like I mentioned, and again, infections, even in your note as physio, document what is their white blood, what is their CRP. All these things are also relevant to you as physio. You need to know these things, and you need to be able to correlate those things with your patient care. And again, like I mentioned, infection is not what we want to treat infection, because we know infection can cause cascade of metabolic changes in their brain that can cause secondary injury again. So we need to be, if you have worried with their CRP, white blood cells are going up, are you also advocating for those patients? Are you also speaking to the medical team? What are they doing regarding the antibiotics? What are they doing regarding managing their infection and all of those things? And again, how is that also related to you as physio? What are you also doing to manage their test? Think about all of these things. So, all right, so let's move forward. Some other classification, you can also classify TBI based on severity. You can have mild, moderate, severe. So of course, you need your GCSK here, your Glasgow coma, really very important. And another one that is OT-led. OT, this is also a domain. We need our OT to be functioning. The OTs are cognitive experts, not physio experts. Cognition is not, physios can still do it, but it's more of OT stuff. Our OT also need to be trained in these things as well. So PTA is another big domain in TBI management. Are we doing that? That is a question we need to be asking ourselves. Are we doing completing those assessments with them? We need to be asking ourselves those things. So post-traumatic amnesia. So we need, there are a lot of tools you can use. Of course, GCS, we're not going to talk about GCS. We have had that discussion in the past. Please go over those lectures, those discussions, and to refresh it, because we need to be able to score this thing accurately. We also, and again, that day, I think I also talked about limitations in some of these things. Like somebody have got dementia anomaly, somebody have talked about those. How do you stimulate? How do you inflict pain in your patient to get some responses? We have talked about those things. So we need to be able to score these things. There's no time to go over that again. Please go and check those videos. So now, like the post-traumatic amnesia here, this is a very, very big thing in TBI patients. This is OT-led domain, OT-led domains. So, so it's just, so what it means generally is just generalized cognitive disturbance, generalized. Some people can be confused, they can be disoriented, they can have retrograde, amnesia, all of those things. Some people can be delusional, they can be agitated. So you need those scoring tools, like Westminster's post-traumatic amnesia scales. You can use GOAT to score you. Some people use CAP, depending on what you want to. For instance, now if I'm using Westminster post-traumatic amnesia scale, for instance, that may have, like, the modified version may have maybe 7 orientation questions. There are 5 memory. There's a part that has, I think I've got the picture. I've got the I think I've got that here. So there's a part that has this orientation. There's a part that talks about picture. Show them picture. Maybe you go second day, you have them to tell you about those pictures. You show them yesterday. All of these things are really, really important. And you can also use this again to talk about the severity, to assess the severity of the traumatic brain injury that somebody has had. And this is also what we want OT to be able to do. Because all these things, again, is also linked to their advanced care. Like when they are now stable, we want to discharge them. We want to, like, how do we progress their cognition? And again, we can also feed some of these results to our MDT. This is what we found. So all these things are really, really very important. So, again, This is also a big domain. How do we score these things? How do we correlate with patient care? We might not be able to talk about that in this presentation, but it's something again. I can have a joint section with one of our OT colleagues here, and we can have discussion and like the person can talk about maybe OT perspective to all these things. I can talk about physio perspective to all these things. But these things are really, really very important when it comes to managing UTBI patients. All right. So I'm not going to talk about CAP. So in terms of severity, of course, we know GCLs, they are mild, moderate, the numbers and all of those things. But for the PT here, let's say for instance, somebody that is mild, like we can assume they've got mild injury, mild brain injury, maybe less than 60 minutes. The durations of the post-traumatic amnesia may just be maybe 5 to 60 minutes. Moderate maybe less than 24 hours. Severe might be longer than that, something like that. So this, like I mentioned, these are stuff that are also very important. Even with MDT management, we can feed to the doctor, we can speak to the consultant on these things. And let's continue. So are we still there, please? Is it making sense? Any questions so far? Or is it looking abstract?
We are here.
All right. Is it making sense at all?
Yeah, it's making sense.
All right. Thank you very much. So so let's have brief discussion here. So what are the clinical, from our experience now, what are the clinical presentations and potential complications somebody can have following TBI? I think it's 3-in-1 questions. The clinical presentation somebody can have, their complications, and their management, acute management. If you pop some of your ideas in the chat box, share your experience with us, you can just say, okay, complication, this. If you are writing on management, this is what we do. If you are writing on clinical presentation, put whatever you want to put in the front like that. So let's share knowledge here. What do we think from our experience? What do we think? What are their clinical presentations? How do they present? TBI patient, how do they present? Now we have discussed different things. We have discussed, the type of injuries patient can have. We have discussed if we go to their bedside, what should we need to be checked? Oh, check the ICP, check their CPP, check their mean arterial pressure. If they are not documenting it, get them to document it. Work with it as physio, something like that. Yeah, great. Now we are going to their bedside. In our head, we should be forming some things in our head. How is this person likely to be presented? Now, for instance, somebody have got, what is it now? Let's say MCA stroke. We know, yeah, there might be contralateral, maybe upper limb affected. And we have those clinical things in our head. But this is not stroke now, this is TBI. Who are they likely to be? Like in terms of presentation, how are they likely to be presented? And in terms of management, what kind of management do we want to be doing with them? And maybe if we don't treat, maybe complications. Even if we treat, sometimes people will still have complications. What sort of complications can they come up? If you pop some ideas in the chat box, please, let's have some discussion. And if you want to open your mic, feel free. It's just discussion, sharing knowledge. Yeah, feel free, open your mic, because what we will be doing with them in the outpatient facility or in the community level is quite important again, that we do some of those things in acute hospitals.
So I want to talk on the clinical presentation.
Yes, ma, go ahead, ma, thank you.
So I think one of the clinical presentation, there could be altered level of consciousness.
Yeah.
And the muscle tone, I'm thinking the muscle tone will still be normal.
Okay.
There will be no spasticity at this stage. And that's all I can say for now.
Okay, thank you very much. Yeah, altered level of consciousness. Yeah, there's an impact to the brain. Yeah. There will be problem, there will be disruptions, there will be either whatever injury you've got, either focal, this penetration, that can affect your level of consciousness. Yeah, great. Thank you very much for that. Yeah, let me see what people have written in the chat box. Please pop your response in the chat box. Yeah, PT Stella, raised ICP. Yeah, like we keep saying. Yeah, elevated head. Thank you very much. I think PT Stella have written some treatment way. Yeah, if somebody have got head injury, they are bleeding in their head. Do we want to put head down position? Do we want to put their heads down? We don't want to do that. We are not stupid. This is just common sense. Great. We want to put their head up position, which means, again, from physio perspective, all these postural, what do we call it? Postural hypotension. You don't want to go to their bedside and try those things with somebody with acute TBI injury. You don't want to go to their bedside. Great job. Thank you very much, Peter Stella. Can we have more response, please? Can we have more response? Yeah. Can we have more response? Great. Yeah, let's see. Yeah, PT Jamil, it can result to hemorrhage. Yeah. People can have hemorrhagic stroke. Yeah, either direct injury or secondary primary injury or primary injury. Yeah, people can have stroke-like presentations. People can have that. There can be rupture, even at the point of the attack. There can be rupture of all those vessels, all those medial cerebral artery, any structures can be ruptured. Yeah, great, excellent. There can be stroke-like presentation. There can be that hemiparetic presentations in them as well. Great. Seizure, yeah, of course, there can be focal change, electrical disturbances in their brain. Please, guys, put response in the chat box. Yeah. Keep it, let them come through, please. Yeah, there can be seizure. Yeah. So we already know, yeah, it can be presented anyhow. It's not like one of the questions I asked when we started this presentation was, how is that different from other neuro condition like stroke? If somebody have got stroke, we know the chances there that, it might be on hemiparetic side, but in TBI, it might not be like that. So you just assess and you treat what you see. So two TBI patients might not be presented the same way. That is one of how TBI is quite different from maybe other neuro conditions, like stroke, for instance. So we have to know that as well. Yeah, there is one big response here. Thank you very much. Let me see. Yeah, PT Hamad. Yeah, presentations, weaknesses, loss of sensations. There can be amnesia, loss of consciousness. Great stuff. Vomiting, nausea, headache. Good stuff. Yeah, these are their presentations. Yeah, weaknesses can be anywhere. It can be paraplegic. It can be whatever. It can be hemiplegic. It can be anything. There is no pattern to these things. That is the point. There is no pattern, loss of sensation. It just depends on the area and part of the brain that is being impacted. There is no pattern to it. Thank you very much. In terms of complications, they can have DVT, pressure sore, due to immobilization, long run osteoporosis. If they are not standing, they are not walking, there will be osteoporosis. That is why our long-term management are really very key for this patient. Yeah, and in terms of complication in acute hospital, what are we doing with them? We are trying to prevent those secondary complications as much as we can. If they are in bed, we don't want them to lose tone in their leg. We don't want them to go into foot drop or contracture or whatever. We don't want those things in bed. We don't want DVT. How do we prevent that? Physio-wise. It's not just physio something. We need medical team to put them on prophylactic medications. We need physios to be doing ourselves. Some may be on touch stocking. All those things are really very important. If they are able to mobilize out, we can start mobilizing, early mobilization to prevent all of these things. Yeah, chest congestions, great. That's another thing. Chest congestions. If somebody has got brain injury, they are now very drowsy. They have low GCS, or some are even being intubated and sedated. We know there will be chest concern. They are not moving. They are not cleaning their airway. They have low GCS. That their cortical control is lost at the moment. So these people can be congested chest-wise. Thank you very much, Peter Hammer. That's a great one. Yeah, let's management. Yeah, let me see. Cortical or yeah, there can be abdominal posturing, decorticate. I've mentioned these things when I was talking about GCS in the past. Decorticate. You find the upper limb going like this. Just remember decorticate towards the core. These are stuff physio should be able to. You don't have to go. When you see it, you should know it. See it, know it. That is it. See it, know it. Decorticate towards the core. Towards the core, like that. Just look at my hand towards the core. Decerebrate, upper limb is just going into extension. That is it. You don't have, and you should know again, somebody is having that, let's say, extension tone, extension posturing in the upper limb. That might tell you that they really got significant damage. If that makes sense to somebody. Yeah, PT Bashir, clinical presentation, utter level of consciousness, motor sensory disturbance, respiratory, cardiac compensation, great stuff. Yeah, principle of management, ensure oxygen provision to the brain. We have mentioned that today as well. We want that brain, that sufficient blood supply to their brain. Because if you don't give them that blood supply, other area will start going into, they will start brain death, power play. And again, we want it to be regulated. We don't want too much blood flow. We don't want too less blood flow. We want it to be regulated. Thank you very much for that. Delivery, improve ICP, positioning. Yeah, what position? PT Stella have helped us. Put them into that upright position in bed. No head down position. No Tendelenburg or whatever position. Head up position. Positioning, mobilization when stable. Yeah, great stuff. Thank you very much for that. Let me look up again. PT Ahmed, yeah. Confusions, yeah. That's PT Jamu. Thank you. Abnormal reflexes, cranial nerve deficit, yeah, 100%. Cranial nerve deficit, a lot of deficit. You can find presentation with upper motor neurons. You can find, these are stuff we'll find. Yeah, thank you very much. Abnormal reflexes, thank you very much for that. Yeah, let me see again. Ankle, yeah, these are part of that's Pitistella, upper motor neuron presentations. You can find somebody going to having clonicity in their legs and all of those things. Yeah, these are really, really brilliant stuff. These are brilliant stuff. Yeah. So the point here is that presentations is not something, sometimes it's difficult to predict. It's difficult to predict. That is why have it in the back of your head. You are going in to see patient with TBI. Have it in the back of your mind. You assess, you do that, your thorough assessment, and you treat what you see. Treat what you see. Two TBI patients might not be presented the same way. That is the point. That is the point. So it is really very important. Yeah, reflex inhibiting procedure. Yeah. Put them in those positions that can inhibit those abnormal reflexes. If somebody is having dichotic to what they call, what do you want to do? You want to leave them to go into that position, that flexion position? No, they will have flexion contractures in their hand, in their elbow, and this thing. What do you want to do? You want to PM, you want to put them in that, put them on this on sling, did I say sling? On splings that can keep the upper limb in extended position. All of those things. Think about all these things. They are really, really very important. Thank you very much. Great job. Thank you, everyone. Brilliant stuff. So let's crack on. So I'm not going to talk about those complications again. We'll talk about those ones. So in terms of diagnosis, so I'm coming back to that ICP again. But that ICP is really very important. Don't forget, this is acute management here. So that ICP is really very important. Like we mentioned, how do you diagnose ICP generally? Diagnosis is not what you want to be doing as physio, but you should be able to spot some things because you might be in their bedside and they might be deteriorating. Don't forget, like I mentioned, somebody can be having arterial bleeding. Arterial bleeding can just go shoo. That's it. And again, don't forget, somebody might be having venous cortical brain bleeding, and they might be stable one day, first day, and third day they are just deteriorating. They are just deteriorating. Like I mentioned, in those things, in those anatomy, don't cram big anatomy that is not relevant to patient care. No anatomy that is relevant to patient care. This is the most important thing. Yeah. So now, again, you are looking at their GCS, the trend in their GCS. Trend is really very important to us in acute hospital. Trend. Not just today. No. Even when you are screening, no, look at their trend. What is their GCS 2 days ago, yesterday, today? What is their GCS? Correlate those things. Then are they deteriorating? Are they improving? Look at those things. Papillary changes. There's something we call Cousin triad. Cousin triad, I think I mentioned it the other time. It's just blood pressure going high, systolic blood pressure, those things. The heart rate is coming down. And again, maybe they are now having some pupillar irregularity, pupillar changes or something like that. That might also be a sign that something is going on. I'm not happy with this presentation. Have you escalated to nurses? Have you spoke to the doctor about that? Think about those things. Yeah. Headaches, vomitings. These are something you might find as well. And again, headache, vomiting might not necessarily mean, yeah, they are deteriorating. Again, because these are common things. Somebody have gone in you find headache, they're complaining from meeting and just yeah. These are something you might find. It might not necessarily mean they are deteriorating. Yeah. Sometimes you just have to work with it. You just have to work with vomiting. Yeah, vomit, great. Let's do whatever I want to do. Yeah. But again, if somebody have got low GCS and they are vomiting, like their GCS is dropping and they are vomiting again, think about from physio point of view, their airway might be compromised. Their airway, because they can aspirate that vomiting to their airway. Think about those things. Yeah. Let's say now yesterday, day before yesterday, they are stable, their behavior is fine. Their OTs are monitoring that, and all of a sudden they start coming down. Altered behavior, cognitive changes. It might also be some clinical signs that we need to pick up as well. That is why we need OT. We need to train our OT. We need to be trained. They need quality training to be able for them to be able to do their job. It's not just physio again. We need physio to do their job. We need OT. We need speech and language therapists to do their job. They are relevant. We need medical team. We need everybody. Everybody must be doing their job. All right. So imaging structure like CT might give you some structural changes. If there is a shift in the brain, if there is anything, if there is a disorganization of the what do you call it, or the gray matter, white matter, don't worry. We will talk about those diagnostic things later on. That CT might not give you exact value of ICP, like ICP, this is ICP, this is no, but CT can give you that structural changes that is happening in their brain. All right, and again, if you need to have that definite value for it, yeah, they might need to be on ICP boards, might need to be an extraventricular drains. I'm going to show you some of these things. And again, when you go to their bedside, you might find patients on those things as well. Yeah, you might find patients. Yeah, sometimes you need to treat patients on those things. They will be on those things, like structure that will be monitoring, like ICP, extraventricular drains, draining their CSF or what do you call it, ICP both, monitoring their ICP value, what is the brain oxygen and all of this thing. You find patients on this thing, you just monitor what you need to monitor. Of course, I will show you some of those pictures here. So that's that about that. So just be aware of some of these things. They are really important for us. Really, this is just like sometimes they might need to use a transducer sometimes to check the pressure in someone's brain. Yeah, just be aware of this. So in terms of, I will still show some of these ICP both and extraventricular drains. So let's just continue for now. In terms of treatment, generally speaking, you might find in acute hospitals, some patient might be ventilated. So if the patient is ventilated, I would say, generally speaking, you might find before they ventilate them, some patient might be sedated. They might be aware of some medications. But even your notes, those things will come into your notes. And again, medication like sedative agent like propofol, amphetamine, there are a lot. Look at what the ones they are using in your. If you don't know it first time, second time, yeah, Google it. Write it somewhere. You go see maybe similar patient. Look at the medication, their drug codex or whatever you call it in your hospital, their drug charts. Look at it. These things are relevant to physio, to acute physios. It's not just go to their bedside and do PM and run away. No, PM again. It might not even be their problem at that particular time. It might not even be their problem. If I do that and running away, you are more than that, just that PM in some patients. Okay, look at their sedative agents. Oh, they are propofol, amphetamine, whatever. Some might even be on paralytic agents like roculum, atraculum, or those medications. Know those medications. So if patient is being sedated and paralyzed, so that means they cannot breathe. They cannot breathe on their own. So are we going to leave them? So they need to go on mechanical ventilation. For a patient that cannot breathe on their own, we have paralyzed them. We have sedated them. They do not even know what is going on. We have medically, we have induced them into level of unconsciousness. So please give me one. Sorry, please. I just attended to something. Sorry. I will stay there, please. Sorry. Hello.
Right here.
Oh, all right. Sorry.
Yeah.
All right. Thank you very much. So now, if somebody is being sedated, they are being paralyzed, they cannot breathe on their own. We have removed their cortical control and everything. So now we need to put them on ventilator. If we put them on ventilator, what mode of ventilator are they going to be on? Somebody that is not breathing on their own. They have the ventilator need to be doing everything for them. The ventilator need to take over their breathing, right? So they need to go on mandatory ventilation. You are going to their bedside to see this patient. Definitely, this patient might be in the ITU. They might be in the critical care. And you are the physio, you are the neurophysios. Or, I don't know, what is it now? Or ITU physios going to see this patient. You have to be aware, mandatory. How does that affect me as physio? You think about this now. How does that impact me? I'm going to see somebody that is on mandatory mode on ventilator. That the ventilator is doing everything for them. In my head, I'll be like, okay, if they are on mandatory mode, okay, before I do anything, let's say I need to do something that I need to disconnect the ventilator from them. I need to think about it. Oh, are their ventilatory parameters okay for me to disconnect them? Because I know if I discontinue, let's say somebody is on high values of ventilator, that like their PEEP is really high, their pressure support, don't worry about those things for now. We have another teaching on ventilator. I'm going to talk about that one. Let's just for instance, if somebody is on really high, like their oxygen level is really high, you disconnect them. How do you want them to breathe? So think about, but if somebody is on low, maybe they started winning their ventilations, they started winning their sedation, they are on low values on ventilator, I can still disconnect them and do whatever thing I want to do. So in my head, if I'm going to see them, I will look at their mode of ventilation. What mode are they on? Because sometimes if you don't disconnect something, you won't be able to do some things with them. This is where we need to start thinking. Physios has gone beyond just do PM, go away, or just do this one. Physios are really doing a lot of stuff for patients. So think about that. You are going to their bedside. Think about that. Oh, what mode are they? What are their ventilatory parameters? What is their respiratory parameters? Will I be able to disconnect these things if I need to do some kind of stuff with them? Think about that. Now, a patient that has been sedated and paralyzed, what does that mean to you again as physio? That means let's say for instance, if I suction them, they might not be able to cough. I might not be able to, even if I'm stimulating their carina, if I'm stimulating their carina, there might not be cough reflex. You know what that means to you as physio? They might not be able to clear their airway. Think about all of these things in your head. So again, another thing you might find is, again, with that ventilation, that ventilator, if you put the patient on ventilator now, we can control their breathing. We can control the amount of oxygen we want to give them. We can control, because like somebody mentioned in the treatment plan, we want that good amount of oxygen supply to their brain. But someone that is not breathing well, that is low, they have low GCS or something, they are not breathing well. Do you think they'll be able to ventilate to get in the amount of oxygen they want? No. But in order for us to control the amount of oxygen we want to give to them, we can put them on ventilator. Ventilator will give you that chance to control their oxygen. And again, another thing we don't want to go dangerously high is the CO2. I think I have mentioned in this presentation today that what CO2 does is CO2 is a vasodilator. It opens the heart. Sorry, it opens the artery. If CO2 opens the artery, what is going to happen to the brain? There will be more blood flowing to the brain. If more blood is flowing to the brain, remember your Morocari doctrine. If there's more blood flowing into the brain, what is going to happen? The volume will keep going higher. If the volume keep going higher, there'll be compression. You don't want that. So we want the CO2 to be regulated. Is it making sense to somebody? Even on ventilator, again, we can still control patient CO2 on ventilator. We can look at their ABG, we can look at, there's something we call end-tidal CO2. We can look at those things and correct their, what is it, their CO2. The amount of the gas they are breathing out. We can regulate that with ventilator. If that makes sense. So again, so that means before I go to patient bedside, please, PT Mustafa, please. PT Mustafa, please. So that means if I'm going to the patient bedside, I want to, let's say I'm going to the ITU now. I'm reading the medical note. I'm going to look at their drug chart, look at the medical documentation. Are they sedated? What is that medication? Are they on? And sometimes you might find, sometimes they might say sedation hold. Sometimes they might say, oh, bolus their sedation. Maybe nursing staff now. Let's say when they did some rolling, the ICP just go up. What the nurses can do is they can quickly just bolus their sedation. If they bolus their sedation, they just increase their sedation. That will regulate that will reduce the impact of whatever activity you are doing with them, like that rolling activity that's impacting on their brain. So the ICP will start dropping down. So we are going to the bedside. You look at what sedation are they on? Are they on sedation winning plan? Have they started winning the sedation, or are they keep going higher up, like hop on sedation? You think about those things, you check. You think about and you make sense of those things before you go to patient bedside. And again, I talk about mandatory ventilation. CO2 is also another thing that you need to be aware of. So if I'm going to patient bedside, I want to check. There's something we call ICP protocol. I don't know whatever we call it in Nigeria, but it's something we also, as physio, we need to ask those things. If you are going to treat what do you call it now? Traumatic brain injury patient. If it is not written in the note, get doctor to document those things for you. Oh, what is the target CO2 we are aiming at? Because again, as physio, your activities, aside from maneuvering the ventilator, this is something we need to be skilled at, maneuvering this ventilator. Sometimes I look at the patient, oh, yeah, this CO2 is too high. Oh, let's pop some CO2. Let's pop out some CO2. I might change their tidal volume. I might change their pressure support if they're on pressure mode, something like that. And if you cannot do that, and again, beyond maneuvering ventilators, all those things, your techniques you want to also do for this patient can also increase their tidal volume. And anything that increases patient tidal volume can make patient to puff out CO2. And that in turn, that in turn again can bring down their CO2. Again, we don't want CO2 to be too high. We don't want CO2 to be too low. If CO2 is too high, what is the impact? We have mentioned it, vasodilation, more blood rushing to the brain, compression, we don't want that. If CO2 is too low, what is going to happen? Vasoconstriction, less blood flowing to the brain, ischemia, brain death. Oh my God. Is this thing making sense, please? Hello?
Yes, sir.
Yeah. So let's think about those things. So ask the medical team, what's the CO2 target? What are we aiming at? Ask them. Again, ask them about cerebral perfusion pressure. I mentioned that before. Ask them, and again, the medical team, ideally, they should tell us, is this patient going to be on scale 1 or scale 2? Usually, they might be on scale 1. Scale 1 is their target, keep it above 94, 95. They want the oxygen, because we want good amount of oxygen to their brain. Something like that, you'll find that. If it's not written, get them to do these things. Talk to them. Demonstrate knowledge. And again, there's something we call brain tissue monitoring oxygen, something like that. You can find PbO2, something like that. We want that again to be on the high side. These are documentations you find. And if they are not doing this thing, get them to do this thing for you. So ventilation is a way of managing ICP. We have talked about why patient could be ventilated. And again, if somebody is, I think I forgot, if somebody is sedated and paralyzed, because again, if they are coughing, even let's say they are agitated, they are confused, and they are coughing. What is that? How will that impact their brain? That is likely to worsen their ICP. Or if we have a patient that is very agitated on the wall, they are just moving head up and down. If they are just moving their head up and down, what is the impact of that to the ICP? It's going to worsen the ICP. You might just sedate some of them. Just calm them. Let them be calm. Put their head in the midline upright position at 30 degrees, 15 degrees, depending if it's not injury or any other polytrauma. Put them in the midline. If that makes sense. So think about all of these things. It's really, really important. And again, you might have somebody with other injury, like maybe neck injury or something like that. Some people might be on collar. So again, if collar is too tight or something, these things can also compress what is it in your neck? Carotid artery. Or maybe venous return, jugular veins. All these things can also impact on the intracranial pressure. Tight clothing, like too tight, and these things can impact on intracranial pressure. Think about all these things when you are at your patient bedside. Think about these things. They are really important. Medication-wise, you can have some medication. I've talked about some of them indirectly today, like propofol, amphetamine, those ones. You can have some medication that they need to be on in order to boost their blood pressure. Because if their blood pressure is too low, their brain will not be getting enough oxygen. You can find some people on NORAD, you can find some people on metronidazole, vasopressins. But then you are at their bedside, check. Some might be on different infusion. Check those things and pay attention to those things. Make sense of those medications. Again, sometimes, let's say I want to treat a patient and their blood pressure is on the low side. And I know if I do something for them, their blood pressure is likely to drop. Let's say I want to do normal function, for instance. Their blood pressure might drop. So I may first of all ask the nurse, oh, okay, if I do these things, is there any scope for you to, anything you can just bolus their maybe metronidazole or something? Is there any scope for you to go high up on their NORAD or their epinephrines to increase their blood pressure? You ask those things. Those questions are really very important. Don't just, even with your normal PM, even though normal PM might not really have significant impact on patients because it's just passive movement. But again, if you are doing normal PM, patient is agitated, you might make the ICP to be worse. Think about all this. Don't just go to the bedside and just do this thing and run away. No, it's not like that. Get some scientific knowledge about what you are doing and why you are doing those things. If that makes sense. All right, let's continue. So, like I mentioned, ICP protocol, get your doctor to document the target CO2 for you, and the CPP, the what's it called? Even positioning in bed, get them to document those positions. And everybody must be addressed, like everybody must be compliant with those things, with those positioning. It's really very important in this patient. And there is surgical procedure as well. You can find the compressive cranectomy. Yeah, I'd like to talk about this one first. Yeah, You can find this procedure like decompressive cranectomy, like removal of what do you call it now? Some bone flap. Let's say, for instance, now somebody have got, if you look at this other one here, like the brain is really going into compression. What do you want to do here? You need to make a hole, or you remove some bone flap. If you remove the skull cannot expand. Now, what you are doing is, if you remove some part of the bones in this patient's skull, and you put some, let's say, some skin flap there, skin can expand. So that can make the brain a little bit like, that can make, what do you call it now? That can further make the brain to accommodate whatever changes that is going on in their brain. You can have that cranectomy. They just remove some piece of bone in the skull. They can put some, what is it there? They can put some skin. Yeah, skin can still expand, but the skull cannot expand. Some patient can do. And again, from physical perspective, if you want to do rehab with this patient, and again, some people can even be agitated, and you see in their head, it's just skin. There's no bone. You just get them to wear something, protective aids in their head. These are like, because if they fall again, if they hit that, it's going to be terrible. It's going to be very, very terrible for them. And sometimes they might just be for some surgical procedure, you might find I just drill some holes in some patients and just relieve some pressure in their head. These are stuff you can also find. So that is that about that. Like I mentioned, this is just, you might find this kind of screen. Oh, I didn't have something here, but you can find this one. If you look at this orange one, you can find this is high CP. You can find your SpO2. You are monitoring all these things. You can find your end-tidal CO2. Like I mentioned, end-tidal CO2 is used to measure CO2. Aside from CO2, you are getting arterial oxygen, you are getting on your ABG. Your ABG can give you oxygen, CO2, carbonate, their pH, and something. You can also measure directly on the bench and see. This is the 3 point. Don't worry about this thing. We'll discuss in detail later. So this is the arterial blood pressure, the arterial line, the ones that come from the radial artery. This is the reading. You see this one in bracket here. This is the mean arterial pressure. So work with those things. What is the mean arterial pressure? What is the arterial pressure? Look at the screen. When you are doing this thing, monitor this thing. Look at the screen and work with the values you've got. If that makes sense to somebody. All right. So yeah, I think I jumped something here. Yeah. So this is yours. This is just another thing. This is from Southampton NHS Trust. Yeah. So this is like some of the protocols you might find. That, for instance, like somebody is on ventilator now, you don't want the PEEP to be too high, because if the PEEP is just positive end expiratory pressure. If the PEEP is really too high, what the PEEP does is PEEP is just like your functional residual capacity. Let me just explain it in a simple way. It's just like if I want to blow a balloon now. Imagine this is a balloon. The first set of air that I'm going to pump into the balloon is going to be really difficult for me, right? Now, after I pop that initial air in the balloon and I start pumping air, the rest will be more easy for me. The first set of air in that balloon is my PEEP, is my functional residual capacity. If I remove someone's, God forbid, if I remove someone's lungs and I put it on water, like I remove someone's lung, God forbid, and I put it on water now, the lungs will float. What is in that lungs that makes the lungs to float in water? That is the PEEP. That is the functional residual capacity. Let me explain it. If you remove lungs and you put it on the table, it's not going to completely deflate. That air that you have in that lung that does not make it what we call functional residual capacity. I don't know if somebody understands that. Now that PEEP is on the ventilator. So I can use that PEEP to recruit. Let's somebody has got lung collapse or somebody is deteriorating, they need oxygen or something. I can increase that PEEP for them on ventilator. Don't worry, we still discuss those things later on fully. But for now, just little things. So now that PEEP, if I'm working with TBI patient, I want to be careful in adjusting that PEEP. If I ever adjust it, that can increase the intracranial pressure, interthoracic pressure. And what interthoracic pressure does for patients is it can, of course, their venous return can be decreased. That means their mean arterial pressure can be reduced, even venous return can be reduced. That means tentatively blood that can be flowing to the brain can also get reduced. So I want to be careful in manipulating my people. There are some other things. Again, let me just look at some brief ones. I can just quickly tell you that again, you can look at sodium, for instance. Sodium is also another way, like let's say, for instance, now that the medical team can use to adjust. What is it now? They can use to adjust ICP. So if they want to keep, so let's say somebody has got brain bleed, lot of fluid in their brain now. So if they give them, maybe they make sodium, they make their sodium to be a little bit high. They can give them sodium infusion, for instance. If they give them sodium infusion, what that will do is it's going to make their circulations to be hypernatremia, like a lot of solute, a lot of salt in their blood. So if you remember your physics in secondary school, osmotic process, what do you call it? Osmosis. Now, osmosis is just you are moving fluids, you are moving water from the point of, what do you call it, the less concentrated area to more concentrated area. Somebody have got brain bleed, their brain is full of water. So you want water to leave the brain to come to the circulation. They can use sodium. So sometimes when you look at their lab, their blood lab, you see sodium on the eye. Why is this sodium? You don't have to be worried sometimes. It could be maybe they are using that to regulate the fluid in their brain, if that makes sense. You can find, again, glucose. The glucose, they like to keep the glucose normal. You will find it, they will keep monitoring the glucose. Because if sugar is too low in their brain, problem. If it's too high in their brain, problem, because of time. HB, you might find people again, they might be needing repeated blood transfusion. This seems very simple to correlate. If they have low HB, what is going to carry their oxygen to their brain? Because their brain still need oxygen. You might find that again. I think I have explained the temperature the other time. Is it that you keep the temperature low or you keep it normal? Because if the temperature is high, what is going to happen? Infection, fever, more metabolic activities in their brain, more productions of CO2. You don't want those things in their brain, because CO2 again will continue to open up their blood vessels, more blood will keep going to their brain. And again, more brain, the brain will keep demanding more and more of oxygen. And they might struggle to get those oxygen. Before you know, the oxygen requirement will start going up on ventilator and all of those things. So we want the temperature to be on the low side, or we want it to be normal. If somebody is now hypothermic, high temperature, what do you want to do? To escalate to them. They need to do something to bring down their temperature. If that makes sense, there are a lot of things I can, but I will just keep it on that, because I think another one that we might also need to talk about, I think I've talked about it indirectly the other time, is about don't do something that can increase their tidal volume beyond expectation. Because if you do that, tidal volume is just normal breathing that you and I are doing now. Breathe in, breathe out, breathe in, breathe out. If you now do something that can make them to start hyperventilating, like that can give them big breath, that if they need to breathe out, they will not breathe out a large amount of CO2. You might still do some of those techniques as physio. I'm going to show us. But still do some of those techniques as physio. But be careful that if you overdo that thing, that can impact on their CO2. And if the CO2 goes dangerously low than expected, what is going to happen? Basic constriction. So think about all of these things. They are really, really very important. So this is just the EVD I was talking about the other time. You might go to patient bedside, you might find these things. Don't be worried, don't be panic. If you need to do your treatment, you can still do your treatment. Yeah? But just ensure no movement, you are not moving, or you are not changing their position or something, this patient. Because these things are set at a norm, as there is a particular range or angle, these things are being set. So you don't want to. And again, sometimes, let's say now we've been treating them, they are doing well, they are awake, they are okay, and we need to do rehab. We need to get the nursing staff to clamp some of these things for us to do our rehab. Then after the rehab, the nurses will clamp, and this patient will do. Physio do all of these things. These are some stuff physio do. All right. So just to be aware, shunt again in PITS, I will still come back to this one. I won't do that now. I think there is a section with got PITS. So I'll talk about VP shunts later on in PITS. So I was talking about, let's say somebody now, let's say I was talking about brain protection the other time. If you've got somebody, they remove some sections, some pieces in their brain. If this patient we are seeing them at the level at outpatient, for precautions, we should tell this patient they need to be wearing helmet. Let's say somebody is having balance challenge, like they are unsteady, they are unstable on their feet. They can fall. We know they are at risk of fall. And we have removed some sections, some pieces in their head. Have we told them to get something that can protect their brain? It's really important we tell this, because if they fall again, they can hit their head again. They can, what is it again? Even the part that they've removed the piece of bone, they can even hit that area, and it's going to be devastating for these people. So we can tell them to get some helmet or something like this. Really very important that we tell our patients. All right. So now let's look at case study. So are we still there? Is it making sense? Are we still there? Hello? Hello?
Yes.
Yeah, we are with you, sir.
Right. Thank you very much. Appreciate it. So let's look at typical case study now. Let's look at case study to make this thing really make sense to us. You've got a 67-year-old lady. She was admitted 4 days ago. She's got road traffic collisions. She's got DAI, diffuse axonal injury. She has fractured her ribs, 4 to 6 ribs. There's no flex segment. We have had traumatic rib distance, so you can correlate. And this lady, again, she has fractured her left clavicle and she's got splenic lacerations. What are you checking in the medical note before you go see this patient? Suppose now we have been told by the medical team, handover from the medical team in our board round in the morning, or they sent a referral to us, or you pick them up, in the caseload, you pick them up, this is their presentation. So what are we going to do with this patient? What are we going to do with this patient? So please pop the responses in the chat box. Some ideas, some good ideas. Yeah, thank you very much, Pity Mary, Pity Messi, Igbinoba Messi, thank you very much. Please took that note. Please, can you drop in the chat? Yeah, I am just joining. Oh, okay. I think she's requesting for if we have notes or anything, please kindly drop for her. Yeah, thank you. So, so what are we gonna do? What are we gonna do for this patient? What are we gonna do for this patient? What are we gonna do for them? Pop some ideas in the chat box. There's no right or wrong. There's no right or wrong. So what are we gonna do? So she has fractured 4 to 6 ribs. She had road traffic collisions. She's got flare ribs. She has fractures as clavicle and she has splenic lacerations as well. So suppose the doctor is giving us an handover now. Suppose I'm the doctor and I'm handing over to you. So what other questions would you like to ask me? You know, this is what I've just told you. I'm the doctor. I just good morning. I'm getting a patient on the ward. They are admitted 4 days ago. They fractured their ribs, their clavicle, and they have splenic laceration, some injury to the spleen. And so, what are you going to ask that doctor as physio? What are you going to ask him? Yeah, let me see some good ideas in the chat box. Yeah, Pity Stella. Yeah, she wants to know about vital signs before going to the bedside. Lovely. Thank you very much. Miti Ibrahim, clarification with medical team first because of splenic lacerations. Yeah. Splenic lacerations. You have to be worried. That's physio. You have to be worried. Splenic lacerations. Yeah, you have to clear that. Okay. How is that managed? Did you manage it conservatively, or is there anything you've done or something? Is there? Don't forget, if you have been following this discussion, I try to make this discussion something you can follow through. I think in the past, when I was talking about, abdominal injury, I think I talked about splenic. Sometimes you might find patients, they might say on bed rest. I think I mentioned that if you've been following, thank you, Peter Ibrahim. That's a really good one. If you've been following those things, and again, you've got those videos there, go over those videos again and again. Pass it to people that you think they also need it. This is why we are having all of this discussion. Yeah, you want to clear that? Yeah, you want to clear their? Yeah, can we have other ideas? Yeah, Peter Stella again. I want to look into the ICP. Yeah, you want to ask them. Okay, yeah, how are they being managed at the moment? What is their consciousness level? These are things you want to ask. Yeah, if they're unconscious, what in terms of ICP? Yeah. Any concern about that? You want to start asking those questions. In terms of medication wise, you want to start asking those things. Yeah, they are really lovely stuff. You want to know all these things before you go to their bedside, because you know you are more than, you need to have some medical understanding before you go to their bedside. What other thing do I need to know again? What other thing do I need to know? I can't just go to their bedside and start doing things. I need to know. I need to clear some things for this lady. Because 2 things are involved, or 3 things. Either I don't do anything for this lady, it's either I do something nice and lovely for this lady, and it's either I do something again that can impact on her health. So how am I going to play safe and still administer my duty for this lady? Okay, let's see. Yeah, Pity Hamad, thank you. Yeah, you want to know about their blood pressure, their heart rate, their hopes. Yeah, ICP, respiratory rate, class. clavicular fracture, any brachial plexus injury. Yeah, you want to have that. Yeah, great. You want to have somebody has got clavicular injury. It might be two-third, it might be one-third, whatever. You know, there might be neuromuscular, what is it now? Involvement in this thing. Yeah, it can be brachial plexus injury. Yeah, great. Yeah. Pleural involvement, refracture. Yeah, you're asking some question about refracture as well. Yeah, great stuff. Level of consciousness. Yeah, CO2 level. Yeah, great. It is Stella. Yeah, great stuff. Good stuff.
But your card.
Yeah, HB. Yeah, you're also asking. You're also looking. We are getting some background noises now. You're also looking at their lab. Somebody that have got brain injury, because you know at the level of injury, they might have lost blood, significant amount of blood. Have you checked their HB? At the moment, I mentioned sodium the other time. I mentioned glucose the other time. Have you looked at those things? Those things are quite relevant to your patient. They are quite relevant to your patient. Yeah. Yeah, good. Yeah, great. They admitted. Where are they? Are they on the ward? Are they in ITU? Are they on neuro ECU or neuro ward or wherever they are? Are they sedated at the moment? Are they having a level of consciousness? You are asking those questions. Brilliant stuff. Yeah. Let me, if there is one thing I'm going to tell us today, please, if there is one thing I'm going to tell us today, if you have got a polytrauma patient, my God, this background noises. If we have got a polytrauma patient, I would advise that. Let's say we have. Sometimes you can find patient with head injury, neck injury. You can find thoracic injury. Let's say refracture. They just like this one, splenic laceration. They might even fracture their humerus. Somebody they can also that same person they can fracture their tibia or fibula or whatever. What do you want to do? You have to clear those areas one after the other. Begin to think like that. If they have said somebody have got humeral injury, I am thinking about, okay, have they been seen by T&O trauma and orthopedic team? Of course, that will not concern the neuro team. It's going to be T&O trauma and orthopedic team. Oh, what is their weight bearing status? How is that being managed? Is it conservative? Are they putting any rod or metal or anything, or it's just brace or something? Think about that. If somebody has fractured their tibia or fibula or whatever, you are thinking again in your head, oh yeah, have they been seen by the orthopedic team? Before you go to the bedside, read the note. Clear those things one after the other. Oh, what's the concept? Are they putting rod? Are they putting anything? Are they plate and screw? Whatever, blah, 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 whatever they want to put there? Can they wait there immediately? Even though you know you may not be getting them out of bed, but clear those things and put it in your note. Caution. Put it. Caution in your note. Oh, right. If I'm writing notes for this patient, for instance, I'll put caution. I'll see maybe later on I might just come up again about how we write some notes. How we write those notes. Maybe neuro, how you write those notes. Maybe no, this one we do patient treated, this needs to be writing, then treatment continue. Rubbish notes.
Like I just pay that.
Rubbish notes.
I just pay that rent, you know. Make it come.
It's a freeborn, please.
I send the phone when I buy commit, you know.
My God. All right. So clear those areas one after the other.
Then please let that guy tell you, I want those things to be done this week. I know say that one.
Pretty freeborn, please. Can you mute yourself, please?
Me, I don't know the name of the chemical now. I told you, say me.
Oh my God.
You say you want.
Please, sir, hello.
What do you call
is the admin still there, please?
He says Israel say he won't know he won't ask capital to know what you're supposed to buy.
How can we get him to be mute, please? All right, thank you very much. So like I was saying, clear those areas one after the other. It's really very important. Oh, what is the weight bearing? Can they weight bear? Is it non-weight bearing? Is it clear? Put it in caution. Right humeral fracture. Caution.
No wonder waiting it
manage with this. It is this manage with that. Like in these patients now, they have got refracture. You should think about that as physio. What if this patient is chesty? Can I do percussion shaking? I'm worried about those things. I'm checking in their notes. Splenic laceration is a concern to me. I'm thinking about how that is being managed in their notes, if that makes sense. Now, this person has had diffuse axonal injury. This might be, I'll be like diffuse. This might be a big injury. Even I might not need to think about too much of anatomy. I will just ask the doctor. Or I'm checking in their notes. What is their GCS? How are they? Where are they at the moment? How are they responding to treatment? What treatment are they doing to them? What is their trend? What is their blood pressure? Or what is their herbs? Check those vitals. What is their laboratory things? Check those blood. Check everything. I'm thinking like that. And left clavicular fracture, how is that managed at the moment? Yeah, any restriction, anything. Think about those things. They're really important. So, like I mentioned, you are looking at the neuro, the scan they've done, everything. You are checking those things. If they are sedated, ventilated, you are looking at those, depending on where they are. You are looking at their orthopedic injuries. You are looking at systemic, their past medical history, their social history. Even if you cannot get social history from social history now, might not, depending on where they are now. But it could be me just walking down to the family member, just ask them quick question from the family member. How were they before all those things, all those kind of things? How were they before? How did they normally manage? Get those information from them. So get comprehensive, anything you can pick that is relevant to their care, pick those things from their notes. It's really important. And again, look at the medical plan. Sometimes you might find a medical plan. Generally speaking, for somebody that have sustained brain injury, what we want to do is prevent secondary injury, secondary complication. Secondary complication. They have impacted their head, What we want to prevent, we don't want too much of bleeding their brain. We don't want their ICP to go high. We don't want them to lose their consciousness. We don't want them to die. We don't want them physio-wise. We don't want them to lose tone. We don't want them to have chest complication. This is what we want to do. If they are confused, OT-wise, let's reorientate them. Let's improve their cognition. This is what we are thinking. So again, like I mentioned the other time, if suppose this patient is in the ITU or something, you want to check their ICP, sedation, paralysis, CO2 level, blah blah blah, head position. Check those things.
Hello, Festo.
How
we did, huh? And so you know, great as of me.
Can somebody get this? Can somebody get him to be mute, please?
I is NROH.
So this is very important.
Chinedu still did there.
Can they be removed? People making noise like this.
Civilian did there. No, good job, good day. No, what I mean, Denta. Which officer is the HOD now?
Pretty Freeborn, please, can you mute yourself?
Let the host meet him.
Okay. Adio.
No, is the host not here?
He's a lieutenant commander that time. I very well for a course.
This man is just taking our time unnecessarily.
Did they post him back after he has finished his course?
Can we get the host so that we can finish this thing and go, please? Can we get the
host? You go give me the link where can they join you now?
How can you join?
But they send everything out. I would like to be joining. So that thing they never stop him.
I'm not comfortable continuing these things, honestly.
My child is having a dental, so I'm thinking of bringing her down, but I need to know. I don't actually know when they are holding their clinic. You understand?
Okay, so I remove you. It's showing from here that you are the host.
All right. So let's continue. So the patient, so this same patient now, we have checked their notes. I've gotten the
okay, I could just go meet us. No, they are even NHIS patient. They have NHIS.
I think we might need to end this
We
thing
have
here
about
today.
3 hosts here. We have about 3 hosts. Let one person meet him.
Now my physio
I think Clara and Kofi,
The host is not in meeting.
they can
maybe
meet
admin
him.
officer.
How could this be happening? The host is not here.
Captain Akio Mina.
Maybe we'll just end this thing here
But
today.
since they are,
We might take the case study next
where
time.
is it going
I'm
to?
not comfortable with this, honestly.
So who are they bringing?
I'm sorry. So we just end it here today.
It's not the HOD for Fabi.
All right. Thank you very much, everyone. Thank you for joining. So I'll just stop here since the hosts are not here. So
The
we'll
young
caution
shall
them.
grow.
Just stop here today. Thank you.
So now,
all right.
Actually,
see you next time.
I just want to know,
Can we continue?
They shy and they are well registered. So it's just to walk
Can we
in.
continue, please?
Let's
just ignore him. The ones we can get, we'll get them.
Because
I'm not comfortable. I'm sorry. I'm not just comfortable with it, honestly. So I'm not comfortable. I'm sorry. So we'll just continue.
Or can I call the host? Let's see whether I can meet him.
Yeah, if you can do that.
I call Chinedu, Chinedu number, not the go. I send out
Okay, let me call the host.
Like me. Say Chinedu. Me, I know have even with Chinedu, it's something I can just sort out. But if those say I give na my friend, I can just talk to her. From a donor, and I donor, not be your sister. So that won't have no any problem. I mean, we cannot get issue. But when I come now, if they want to say, okay, I have to see everybody's face. You understand? I want just code the enter code come out. It is very. As this is when I come out, I never hear that to that. I never hear that to that side. I didn't know because of these children. Pascal. Which person? Don't mind. Don't mind. It is so. Oyami, I'm thinking of bringing out.
Oga Freeborn, can you please mute yourself?
But actually, I will try to call Chile if there's something we can just say. Because now this, now this, if like say I'm all like a grow up, so the pain is terrible. Understand? Oh God, the first level get a clinic, for airport. Yeah. Oh, let me call. Now my hey, God bless you. Make I drop now, and even first level the Air Force. Yeah, those are the state Kenya. So, yeah. Thank you. So I can take her to Air Force. Yes, my friend, I did visit together for very much as Air Force. And they have a clinic that this time. So you don't use Air Force. Let me call her before. Hey, see you. As you don't they tell me, you be like say I just forget. I say I know the.
I think I've gotten him. He will soon meet him.
All right, let's just finish this thing so that we can help you. He has wasted our time already. So let's just finish it. But I honestly, if you know you won't be part of these things, there is no point joining and disturbing others. Does not really speak well of us, honestly. But then let's continue. So our patient now, this patient has had decompressive craniotomy. They've removed some parts, some brains flap in his some bony flap in his brain. So they've sedated him, they've paralyzed him. We have understood that, and we know the reason why they have done that for him. So and this same patient now, they have put him on synchronized mandatory ventilation. Don't be worried about that for now. It's like what is it? Modes that can allow patients to breathe on their own, modes that can also allow ventilator to do mandate to give patient mandatory breath. But the one this patient is on now is on mandatory breath. So again, the ICP now, like when they sedated and paralyzed this patient, the ICP is 10 to 15. So, and it's spiking up, like it's just going up and down, like it's spiking up from 15, from 10 to 35. And don't forget, from the explanation we have made before, is we want the ICP to be lower than 20, lower than 25. That is what we want for our patient. Because we know if ICP is too high, that might be dangerously, it might be too dangerous for this patient. We don't want that. So again, so when you check their chest X-ray, please. So when you check their chest, X-ray, we also saw on their chest X-ray that they've got bilateral lower zone consolidations on their chest. Now, and the nursing staff, they tell you that, anytime they suction them, they are getting like ETIC secretions from their chest. This is what you have gotten from the nursing staff. You look into their ABG as well, you find these readings. You look into the CRP, you look into their white blood cell, you find these readings. This is a classical patient, like a real life patient. So now, with these presentations, look out, the injury. This patient had rib fracture. They fractured their clavicle, right? They had the road traffic collisions. They have sedated them. They have paralyzed them. Before that, they have removed some parts, some sections of their skull to relieve pressure, to relieve intracranial pressure. Now at the bedside, their intracranial pressure is jumping from 10, 15, is going to 35 and coming down. You check their chest X-ray. You have seen on their chest X-ray that they have consolidations, like opacity at the base of their lungs. And the nursing staff, they are clearing thick secretions. Their ABG is here. I'm not going to interpret that. Their CRP is here, and their white blood cell is here. If you look at this picture, can we try and correlate these things together and see if we can make sense of these things? These whole pictures of this patient. So if you can look at it, is there anything you can pick out? Is there anything? Do you think, what cautions do you need to take if you need to treat this patient? Or if I may ask, will you be treating this patient, yes or no? And if you are treating them, is there anything you need to be worried about? Is there any cautions? Is there any precautions or anything in this patient? And what is likely to be your priority? The time is gone, so let's just quickly go through these things. Okay. So what are you worried about in this patient? Hello, are we still there? Or Mr. Freeborn has dismantled everything. Are we still here? Hello?
Yes, sir.
Hello?
We are here.
Yes, we are.
All right, thank you very much. Yeah. So this is a real life patient. So suppose you are the physio. So what will you be worried about in this patient? With these presentations, what will you be worried about? So we just put some idea in the chat box. So what will you just put some ideas there? So what will you be worried about? Look at just the whole presentation. They fractured their rib, or they fractured their clavicle. They have removed some portion in their skull to relieve pressure. Their ICP is jumping, is spiking to 35. The nurses are clearing thick secretions. Their CRP
The
is going
positioning.
Sorry?
They say the patient, the ICP rises on supine lying, that is to 35. So you have to position the patient to 30 degrees. On the spine has to be on neutral position.
Yeah, great. Thank you very much. That's a good one. Yeah. So again, ICP that is spiking up, I need to be worried about that. Why is it going up? Why is it going up? And again, this patient is in supine line. Is this position optimal for this patient? No. We need to find a way to get this patient upright. Yeah. What else are we worried about? If you look at the ABG, the blood you have, the anything, the chest X-ray you have, is there anything, what the nurses have been doing, what they are reporting to you, what are you worried about? And is there any caution you want to take in this patient? Any caution, anything like that? Because this thing is best, like, it's best known with discussions. Not me coming, just blast it and run away. No, let's discuss first of all. And I can then say my own part of it. So what are we worried about? Because being able to, pick cautions and these things are really very important. So any other idea? Thank you.
I'll also be worried about the thick yellow secretions, which the nursing staff, they are just able to sanction small amount. So if there could be a nebulizer added, so in order to secretion, and then patient to be able to, be able to sanction more. Thank you.
Yeah, that's a brilliant one, because why we are also worried about thick secretion, they've got mucus plugging. Don't forget again, we have mentioned several times today that CO2 is really dangerous. Too much of CO2 in their chest is really very dangerous for these patients. Okay. Now, if somebody have got secretions, lot of secretions in their chest, that can also impact the VQ matching. That can also make somebody to retain CO2. If they are retaining more CO2, what is going to happen? They will start becoming more drowsy, and that CO2 again is detrimental to their cerebral function, their cerebral perfusion. But that too much of CO2 they are retaining because they are now having secretions in their chest. And that is where we fit into this patient group. Acutely, that is our bread and butter. That is our bread and butter. Thank you very much for that. That is our bread and butter. So we need to help them to clear those secretions. Because if that secretion is too much in their chest, it's going to impact them. It's going to impact them. And that is where we fit in this patient group. So thank you very much. Yeah, she mentioned nebulizers. She mentioned nebulizers to be able to. She mentioned nebulizers to be able to help this patient to clear secretion. So that is also really, really very important. But again, we also have to be careful with giving too much of nebulizers, because especially if patients are I'm just saying that, especially if patients are paralyzed and paralyzed and sedated. Because if you give them, especially hypertonic nerves, if you give them too much of that, you might not be able to clear everything, because with the sedation, with the paralytic agent they are on, they won't be able to cough. Even if you suction them, even if you stimulate their carina with your suction catheter, they won't be able to cough. And if they are not coughing, the chance is there that you might not clear everything, all the nebulizers you have given to them. And again, what does that mean? You are giving them too much of fluid. Like you are adding more, you are burdening their, their lungs. I don't know if that makes sense. We can still give nebs, but just take caution. These are part of things we are worried about. Oh, this patient is sedated and paralyzed. Oh, yeah. Even with my suction catheter, I can still entrain nerves. But I have to take caution with that. I don't want to overdo it. I am doing it based on needs. I know why I'm doing it. So I can just add some. I pass my suction catheter. By the time I'm coming out, I had some nerves and start doing it. I don't want to overdo it. That's what I'm saying. Because that sedation and paralytic agent they are on will be bringing a lot of things in our head, if that makes sense. So now, what is our main clinical priority in these patients now? Your priority is their chest. Your priority in this patient is their chest. Because if they start having a lot of mucus plugging in their chest, it's going to impact their CO2. And their CO2 will impact their intracranial pressure. Now you are fitting as physio. You are fitting into the management of this patient. So, but if I don't understand all these things in the end, because I can, and again, don't forget this patient, they have rib fracture. That means from physio point of view, I cannot percuss that. I may not be able to percuss. I may not be able to do my manner techniques. respiratory valve, percussion, all those things you want. You cannot do it down. You cannot put them in postural drainage. Start taking out some of your treatment plan like that. Okay, this patient has splenic laceration. If you want to mark them, you want to do abdominal mark, you are limited. So why will you now treat them? Start thinking about those things. So you are looking at their injury, you are looking at their presentation they have, you are looking at your toolbox, what you have in your toolbox, your treatment toolbox, and you are matching them one after the other. That is why I said the other time, the patient have got polytrauma, different injury, tick box one after the other, clear them one after the other. They have radial fracture. What is their waist bearing system? What is their leg? Clear those things one after. They have injury in their chest. Have you cleared that? And think about what do I need to do in their chest? And what do I need to be cautioned about in their chest? This is how you think about this kind of patient. This is a really very complex patient, and it needs to be seen with highly skilled physios to be able to manage them effectively. If you don't manage them well as physio, nobody can do your job. The highest nurses can do on the world is to function them. And sometimes you might even need to educate some nurses. You might not need, because sometimes, remember, when you sanction this patient again, your suction catheter can also make some people to be agitated, can also stimulate some, what do you call it, vagus nerve and something like that, can also make the blood pressure to go high or up. Remember those things? Your mean arterial pressure, remember cerebral positional pressure is mean arterial pressure minus intracranial pressure. This is how you are thinking. When you even sanction them, your ICP can also go up and down. The chance is there that it goes, if it's coming down, that's great. The ICP can go up. When you are even functioning, what do you want to say to some of the nursing staff? Let's say, because normally nurses on the ward, physio should be doing, what is it now? Physio can do function, and nurses can also do that as well. But you want to also say to them that this is no kind of patient group that everybody should be functioning every time, like do routine function. No, you only function when there is need for you to do it. Because you know, immediately you pass your suction catheter, that can irritate their airway, that can make the ICP to jump up again. If that makes sense to somebody, these are stuff you want to say to yourself. Just function them when there is need for them to do it, for you to do it, when there is clinical need to do it. If that makes sense. And again, look at this. As physio, you should be able to read their CRP, white blood cell. What does that thing say to you? Infection. Why are they having thick yellow secretion? That is showing that there is infection going. They correlate it. Oh, they are now bringing infection in their chest. Okay, what does that mean? That infection again can make the ICP to work. I think I have explained that metabolic activity, CO2 rising up, all these things will make the ICP work. This is where your bread and butter. This is where you are fitting into this patient group. I don't know if somebody is getting these things. Is it making sense to us? Hello? Hello?
Yes, we are following.
Apart from suctioning now, what else can the physio do?
Yeah, I will still talk about the treatment plan. I will still talk about that now. Thank you for that. I will still talk about that. Yeah, let's move forward. So now, my questions is, now I've just bring them up. Refractor, I've talked about it. Manner techniques. I want to be careful with manner techniques. But again, if it is one side, I think in this patient it's just one side. Yeah, I can still do my manner techniques on the other side if they are really very skilled. If there is need for me to do it. They've broken their 2 to 4 ribs on the right. I can still do my percussion this thing on the other side. If let's say for instance that they got secretion on the left, I can still do it on the left side. But don't forget, this is bibasal something. Yeah, I can still do my rib spring, whatever manner technique, percussion, spiritual, I can still do it on the other side with them. Yeah. So, but be aware, refracture, I need to take caution. Now they are spiking to 35. And don't forget, we want to keep the ICP less than 20, less than 25. Why are they spiking to 30? You want to ask the nursing staff. By the time they spike to 35, how long do they take for that 35 to crash down? Because you know, again, if you now do your physiotherapy, let's say I'm doing, like I just mentioned, I can still do manner technique on the other side. Let's say I'm doing it on the other side, and then I spike to 40, and they are sitting on that 40 for like 40 minutes or 20 minutes. Do you know what that means to that patient? High intracranial pressure, brain compression, hydration, correlate those things we said earlier. So you don't just jump to their best and start. You need to know all these things. Otherwise, you might be endangering the life of the patient, because you know any of your physio skills can worsen their problem. And again, if you don't treat them, problem. If that makes sense. So you are correlating those things. So you ask the nurses. The spiking to 35, it might be when they sanction them, it might be maybe when they reposition them, it might be when they roll them, it might be when they do personal care with them in bed or anything. Ask them, oh, How long does it take for that 35 to crash down? How long? Are they unstable? Are they stable? Ask those questions at the best. Are they stable? Are they unstable? In terms of sedation, again, physio, I need them to be coughing. In terms of sedation, have you also asked them, are we on winning plan? Are we for sedation hold? Or now, when they go on 35, what do they do? What do the nurses, what do they do to bring that 35 to 20 to 50? What do they do for them? Ask those questions. Do you bolus the sedation? Do you increase their blood pressure, like give them metramine or bolus their, what is it now, adrenaline or whatever, to increase their blood pressure so that this thing can crash? Or when they sanction them, they might say their blood pressure just drop down. If their blood pressure, they might say, oh yeah, I just increased their metramine or their blood pressure medication to bring it up. Because if their blood pressure drop down, their mean arterial pressure will drop, their cerebral perfusion will drop. Correlate those things we have mentioned before. So you ask them those questions at the first time. Okay. So what do you do? Did you do this? Did you do that? Ask them those things. Okay? Yeah. Refractor again, you want to be aware if I need to position them now with refractor, they might say maybe the auto are noting, they might say, okay, put the hand, this. Usually clavicle fracture is normally conservative management anyway. But imagine if somebody have got humeral fracture now. They might say, what is it now? Use this sling, use that. If you need to position them in bed, you must also consider their orthopedic injury. If that makes sense to body, you are looking at their injury, see, if you are neurophysio, you have to be very good in ortho, you have to be good in respiratory, not this one we are doing back home. Honestly, if you have respiratory physio, your neuro must be sound, your ortho must be sound. That is why, again, I keep saying we need to separate those things. What is outpatient from acute? They are two different things. If you want to, like this traumatic brain injury patient, if they come to outpatient now, the stuff people will be doing in outpatient is different from acute. It's quite different from acute, because you'll be doing advanced exercises, balance training, blah, 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 proprioception. This is not the concern of this patient right now. The concern of this patient is how I want to stabilize, help the medical team to stabilize the ICP, treat their chest, prevent complication. No, don't forget, complication is what everybody is preventing. The doctor are preventing, you're also preventing complication, and you want them to be stable. If that makes sense. Now, there's also mandatory ventilation. I'm also taking caution about that mandatory mode of ventilation they are on. I'm also looking at that, because I know from, what is it now? From functioning part, if I need to disconnect ventilator, I need to be cautious. I need to think about it very well. If I need to, what is it again? If I need to give them nerves, I have explained that. I need to take caution about that. Think about those things. If I need to switch mode, am I going to put them on mode that will make them to retain CO2? Mode of ventilator, physios can switch it. And you speak with the consultant, yeah, I just changed the mode to this. Yeah, this is why I did it. Everybody is fine, no concern. Because they trust you, you trust them. It might be you go at the baseline, you say, CO2 is dropping more than expected. Do you want to leave it and you just do PM and go? No, you have not done anything. CO2 is dropping and you are doing PM. What is the correlation? Because CO2 that is dropping, ICP will go up. What is it? Their brain cell will start dying and you are doing PM. It is when somebody is alive that PM can be useful. So think about those things. So that is why we need to be skilled in those ventilators and these things. We speak, work with consultant, everybody is working. Sometimes they will even walk to you and ask you some questions. Oh, what do you think? Then they value your opinion because they know you know these things. You speak to them, they speak to you. Splenic laceration, you are so worried as well. I cannot do abdomen mark for them because I know another thing I can do for this patient. Let's say, for instance, they've not got laceration in the abdomen, they've not got injury to abdomen. I can abdomen mark them. I can do abdomen mark to augment their cough because I know they are not coughing because they are sedated and paralyzed. I can do that, and I can pass suction catheter. Nurses can be suctioned, or my colleague can suction, and I can mark their abdomen. If they've not got thoracic injury, I'm just saying generally now to make us understand. If they've not got thoracic injury, I can still do something that can mimic their cough. I can mark them, thoracic mark, and somebody can pass suction catheter. And by the time I will just be doing mark on expirations. I'm sorry, I'll just be doing mark. You'll be passing your catheter out. Can do that. If that makes sense. So think about all of these things. So now, please again, generally, if you are going in to treat a TBI patient in acute hospital, think about their level of stability. First of all, their level of stability. And how do you know that? Speak to the doctor, speak to the nurse. The nurses are always with them, ITU nurses. They will always, patients in ITU are normally, they should be one-to-one, like in good environment, one-to-one, one patient, one nurse. Speak to them. When you roll them, how are they? What is the ICP? Is it jumping up? What happened to their blood pressure, their mean arterial pressure? Is it coming down? Is it going up? What are you guys doing to stabilize it? And when it goes up, does it just sit there? And how long does it take to come down? Ask this clinical, reasonable question. And again, physio-wise, think about it. Why do I need to treat this patient? If you are not clinically indicated, if you do any small thing, you will change the ICP. So you need that good clinical judgment. Think about it. Okay, do I really need to treat them? What is their respiratory picture at this moment? What is their picture? Okay, have you checked the CT scan? It could be CT, it could be chest X-ray. Have you checked if there are any vocal change in their chest X-ray? Look at that English. Vocal change, new changes in their chest X-ray that you know you have to treat them. Nobody can do but you. Have you checked that? Have you looked at their ABG? And sometimes, what are you picking in the ABG? You are looking at the CO2. You are looking at the oxygen. You are looking at the pH. Look at those things. Look at those things. Look at those things. If their CO2, is it going up? If their CO2 is going up, there are a lot of reasons why CO2 can be going up. You don't want it to be going up, right? There are a lot of reasons. It could be that if they are on ventilator now, it could be that maybe the parameters on the ventilator are not optimal for them. That's why their CO2 is going up. It could be because of secretion. Secretion, yeah, physio, that's your job. That is your job. It's because of secretion. Yeah, that is your job. Lung collapse. They are now losing some part of that is your job. You have to do it. Think about those things. You have cleared their stability. You are looking at their respiratory picture. What am I treating? Define what you are treating. Clear indication. Clear indication. And again, patient tolerance. Patient tolerance. What is the escalation plan? And again, let me say this: majority of the situation in this patient group, what you will be doing is risk versus benefit. Risk versus benefit. You have to weigh the risk against the benefit. So if the benefit is too much, if the risk is too much than the benefit, don't do it. But how do you weigh risk against benefit? Again, good clinical education, good experience, because you need to weigh a lot of things. Look at the ventilator parameters. What is their P? What is their this? What is their that? Look at those things. What is their chest? Have you auscultated them? Have you palpated them? Is there indication? How is their chest standing? Is there crepitus? Is there this? Is there that? Are they silent in one part of the lobe or blah, blah, blah? You correlate all of those things and you define in your head, yeah, I need to see this patient. So what will be the treatment plan? Because of time. So positioning we have mentioned, get them upright. Really important. Yeah, there's also manual hyperinflations. There is also, this image, what did I put here? This will be T, sorry, manual techniques. Manual techniques, I'll just change it now. Manual techniques. Now, think about your manual techniques. Oh, they have chest refractor. They have this thing in the abdomen. Okay, if it is one side, like I mentioned, I can still expiratory vibe them on one side. I can still percuss them. I can still do rib spring on that side. I can still thoracic mark them on that side. Okay, on the other side, I can still do it if there is need for me to do it. But define that again. Somebody that have got pain in one side, fracture in one side. Do I really do that? Do I really have to do that on the other side? It's again risk versus benefit. But if there is need for you to do it, yeah, do it. Do it on the other side. Do it on that other side. Suction, yeah, you can do that. Nurses can do that. Everybody should be doing that. But again, if there is a possibility of you not passing the catheter to be eating their carina, if there is possibility of you not eating that, for instance, let's say I'm the first physio that see these people, I can even look at the calibration of my suction catheter and say, oh, yeah, the length of the catheter I need to pass down into the ETT tube or into the trachea or whatever things they have got, here where they have got is 20 centimeters. I'll just document that. So if anybody else needs to do that, they may just do maybe 18 centimeters so that they will not be eating on their carina. Something like just think about, because we know again when you're eating on their carina, you might, especially in people that are maybe they started winning their sedation again, that can make them agitated. That can cause some vasovagal activities that can impact on ICP again. That can make those things worse again. Think about those things. But again, generally speaking, let me say generally speaking, people don't even remember that. Still do your stuff. And again, it's normal when you are doing your treatment for ICP to jump up, it will come down again. That is normal. It's normal. Don't shake. Don't panic. It's normal. When you sometimes ICP go up 20, 30, it will start dropping again. 30, 29, this thing. ICP go up 45, start dropping 40, 39. It will drop down normally because you know whatever you do. So the dropping in physio treatment should be transient. Let me say that again. When you are treating them, they are dropping, their rise in ICP should be transient change. Transient. If they are not dropping down, let's say you function or you do percussion or you do whatever, and the ICP does not drop down, what do you want to do? Get the nurse. Please. If they are, maybe they are awake a bit or something, bolus their sedation. Let's see if the ICP will come down. If they are on, let's say, collar, loosen that collar away, because you know that can also compress their vessels in their neck. Think about those things. If they are slump, they are not well upright, get them upright, put their head in the midline. Think about those things. All those things. All right. Some other things you can do MIE with them. You can cough assist them. Of course, you cannot, let's say somebody that have right and left rib fracture, or they have sternal fracture. You know, I cannot mark their thorax, I cannot percuss or shake their thorax. Now they have injury in the abdomen. I cannot mark their abdomen. So tentatively, my manner technique is gone. I cannot do manner techniques with this patient. This is why we are saying sometimes we need some equipment again in Nigeria. Imagine this patient group in Nigeria. Just imagine this patient group in Nigeria. You cannot do manner techniques. You cannot do abdo techniques. So what else will you do? So do you not think position is the only thing that can help this patient? Even positioning is not something you can categorize like real physio. Everybody should be doing positioning, not everybody know that. So what else are we going to do for this patient? Imagine this patient in Nigeria. Functioning alone is not enough for this patient. So we need something that can mimic that core to bring out that, to go into the lower peripheral part of their lungs, to bring those things, clear those things out. So what else can I do? I can bring out my cough assist and cough assist them. That's fine. So even if I cannot do whatever things, I can cough assist them. That's fine. I can do IPPB with them. I can do now MHI and VHI. If you are very good with ventilator, you can still do ventilator hyperinflation with them. But ventilator hyperinflation and MHI, the one that look like bag, what do you call it? What do you call it in Nigeria again? I've forgotten this thing. So you can still do those things again. But be careful with those two things, because what VHI and MHI will do to the patient is going to give them big breaths. If you give them big breath, even though that big breath is transient, but immediately they want to breathe out, they can puff out large amount of CO2. Don't forget what I explained earlier. So it's something you can do again, but it's something you don't want to keep doing, like do a lot of breath for patients. Because when you do that, what that does is patient can puff out large amount of CO2, and if they puff out large amount of CO2 than expected, what can happen again? Vasoconstrictions. Remember those things. But it's something we can still do to mobilize secretion from lower airway to central airway, and we can then suction. So you need something for your suction to be effective, to work effectively. You need something that can mobilize secretion from the bottom of their lungs, from their peripheral to central airway, then your suction can then clear. If you need to, entrain nerves and this thing, you can still do, but be careful if they are paralyzed, because you might not be able to clear everything. Be careful, like I explained earlier. So these are some of the techniques you can do, because you are limited in this patient. So you need to think about your techniques, think about their injury, think about ICP, and you start doing everything one after the other. You start ticking your box one after the other. So these are some of these things you can do with this patient. All right, other considerations, speak with the nurses. I think I have explained that. I have explained the use of hypertonic nerves. Pre-oxygenation. Sometimes by the time you pass your catheter, you find some patient, their saturation will just drop down. Let's say I did my phone suction or I did my manner techniques, and what do I want to do on next sessions, like on next treatment regimen? What I want to do is I may think about pre-oxygenating them or hyperoxygenating them, so that by the time I pass my catheter or I do my whatever cough assist or anything I'm doing with them, what that does is Even if the out saturation will drop, it will still be within range. Because you want, again, don't forget, you want that nice saturations to be happening in their brain. Think about all these things. And again, sometimes some patients might be agitated, moving head, ICP 35, 40 in the bed. What do you want to, and you want to treat them from chest point of view as physio? What do you want to tell? You know, again, people that is agitated, moving head, even if you want to cough assist them, you won't be able to do that. And if you are also fighting them in bed, that will also keep rising their. What do you want to tell? Please, just bolus their sedation so that they can calm down for me to be able to do my stuff. And in turn, that will also help their ICP. So think about all of these things. I have explained VHI and MHI. Don't worry about those things. Maybe later on, there is a part of positive pressure. We can bring those pictures, explain some of these things. And we should keep, beyond, like I keep saying, infrared, TENS, and such way, they are not relevant in acute hospital. We need acute hospital equipment too, to be able to deliver excellent and great care for patients in acute hospital. Please, really important. So later on, this patient, they wean them from ventilator, they inserted tracheostomy tube, they inserted their tracheostomy tube and tracheostomy weaning. These are physio-led. We start weaning them and everything. We start doing our rehabilitation and everything with them. So that's that because of time. So other treatments, of course, we have done respiratory function, then tracheostomy weaning. We have had discussion about tracheostomy, still the same thing. How you wean somebody for tracheostomy, see this nose, and language coming in, doing your stuff, finger occlusion, all of those things. I've explained those things. Go over those things. Go over those things again. They are really very important. Then spasticity again. Some people might be presented with maybe hypertonicity or something. While they are in bed, even while they are in the ITU, yeah, you are still checking their range of motion in their ankle, especially. If there is need for you to get splint for them, if there is need for you, of course, and you keep assessing their tone. Oh, are you able to achieve pantigrade? Are you able to? Those things are really important. They are really, really important. And maybe later on in this patient group now, we have weaned them. They are not on ventilator again. We have started on a rehabilitation program on the ward and everything, or maybe they've been stepped down to the ward now. Let's say they from ITU now, they are now on neuro ward. We want to manage spasticity. Can I quickly get some ideas? Can we quickly pop up some ideas on how we can manage spasticity in this patient group, please? Thank you very much, P.T. Ahmad. Intermittent positive pressure, that's IPPB, minor hyperinflation. Thank you for defining those things. Thank you very much. Yeah, VHI, ventilator hyperinflation. Thank you very much. Yeah. Can I quickly get some ideas on how we can manage spasticity? How can we manage
positioning? Reflexing, repositioning. Positioning.
Yeah, great. Positioning, really important. Like there's somebody is having like postural decerebrate or something, or extensor tone or something. You want to put them in opposite position to inhibit that abdominal posture. Really important. Positioning, yeah, it's really very important. Yeah, what other thing can we try with them? What other thing can we try with them? Somebody with spasticity, yeah, please respond in the chat box. Open your mic. Let's quickly finish up this thing. Yeah. What other thing can we try with them? Spasticity management, yeah.
Gentle handling.
Yeah, handling, yeah, handlings. How you handle them. Yeah, your handlings, it has to be appropriate. Do not handle, because sometimes if you do something that can continue to aggravate that spasticity, it's going to keep getting worse. Yeah, gently handlings, yeah, therapeutic handlings, yeah, great. Stretching program, yeah, design some stretching regimen with them. Do we need to do some stretching, passive range of motion, blah, blah, blah. Get the family member to support them. Exercising rehab is not just when people are there. Nurses, teach the family, teach nurses, everybody. They should be doing it for them on the ward. Yeah, it's not when Mr. Physio, you are the PM master. Nobody is PM master. Anybody can do PM. Teach them. They can be doing it. Passive stretch, they can be doing it. Yeah, can be doing, because if you don't do it, don't forget, secondary complication is what you are preventing. They can get that secondary complication quickly. Yeah. And again, neuroplasticity concept, you need that repetitive actions, that repetitive. Again. So yeah, what other thing can we try with them? Stretching program, yeah, stretching program, yeah. What other thing can we try with them? Let's finish this thing. Spasticity, of course. We are used to spasticity. Yeah. So what other thing can we try with them?
Painting.
Yes, great. Splinting. We need to splint them. Yeah. Some might need to go on night splinting. Yeah. Some might need to go on night splinting. Some might need, what splinting do they need? Do they need splints that will allow extension or flexions or anything? Think about that. Think about that for them. What other thing can we try with them? What other thing can we try with them? What other thing can we
There's
try with
something
them?
there's something that I found out that used to help patients with spasticity. Like if we do a soft tissue massage on the antagonist of the spastic muscle. Like if the biceps are spastic, then when I do soft tissue massage on the triceps, it used to help them.
Yeah. It's something we can try with them. Yeah, I think that concept about autonomic inhibitions and what is the other one? Yeah, it's something we can try. When you work on the other one can start relaxing. Yeah, great stuff. It's something we can try. Either soft tissue mobilization. Yeah, you can try that. Yeah, it's something we can try as well that can inhibit spasticity. Yeah, great stuff. Yeah. What other thing? Anything from MDT, anything from anybody? Yeah. What other thing can we try with them? I think there is a section that talk about spasticity. Yeah, I think I also like to, we still have a discussion on spasticity on this one as well. But just brief thing. One thing I will say here is spasticity is not just physio things. Let me make it clear and sound. Spasticity is not just physio concern, it's MDT concern. Because a lot of things can aggravate spasticity. We need to rule out everything. Pain can make spasticity worse. Pressure sore can make spasticity worse. Infection can make spasticity worse. Anything, hunger, anything, anything. Confusion can make spasticity to be really, really worse. So think about all these things. Think about who do you need. If you're looking at blood pressure ulcer, there should be treatment for that. The nurses should be doing that because that can increase spasticity. Some of those things here. It's not beyond stretching, beyond our physical stuff, lovely physical stuff we are doing, especially stretching program, passive range of motion, splinting, soft tissue mobilization, weight bearing activities, all those lovely things we are doing for patients. Beyond that, look beyond that. Begin to look beyond that. It's beyond just physical concern alone. There are some elements. I think I've got some of those things I put down here. Let me see if I have it here. Where is it going? Yeah, pain, infection, pressure ulcer, like constipation, infection, bowel bladder concern. Somebody that is deteriorating, medically unsustainable. All those things can make spasticity to be worse. Think about who do you need. If the inflammatory marker is going up, your spasticity will start getting tougher. The passive stretching you are doing easily may now becoming a struggle for you. For those things. So you need the medical team, they need to be an antibiotics and all of this. And again, do you need medication? Do they need antispasmodic agents? I will still come later on to discuss this thing in detail. Do they need antispasmodic agents? Do they need those things? Do they need, what do you call it, gabapentin? Do they need baclofen and anything that can be, depending? Or is it global? Or is it, those ones could be used for global spasticity. And if it is focal spasticity, like let's say somebody has got spasticity in their hand, in their wrist, or they've got it in their ankle, for instance, that is focal, localized to the area, they might give them botulinum toxins, botulinum. If they give them botulinum, that will paralyze that muscle. You can easily do your splinting regime. You can easily do your stretching regime with them. It can even be you putting them on that program. While they're having their Botox, you're also doing your splinting and everything, weight bearing regime with them, for you to be able to gain that planted grade, that adequate range of motion in the ankle. It's not just physio concern. Think about who do I need? Do I need doctors? Do I need nurses? Do I need family? Not just your concern, it's everybody concerned. That is the point I wanted to make about spasticity. We'll still call later. Of course, therapeutic handling position, early sitting, standing. We know what sitting and standing, early mobilization will do for our patient once they are able to do it. It will increase their awareness. It will, early weight bearing, like somebody mentioned osteoporosis the other time, that can help patients to prevent that. In fact, their alertness, their orientation, everything are improving. Greater sensory stimulations. No, look, what do you want to use to improve their auditions, like radio, like familiar voice? You can ask them with their consent, record the family member voice. You can play it for them during their rehab. Yeah, something we do. Record the family member, like, hello, how are you today? Are you able to do physio? Are you doing well? Familiar voices. Even when the family are not there, you can record it with their consent on their phone and play it for them during rehab. Get good music, what they like, get those things, use those things. And make your rehab to be functional, not just payment. No. Think about functional activities with them. Think about what cues do you need to give to them. Remember the neuroplasticity concept. Give them external cues, not just internal cues. All these things are really very important. In terms of, it could be maybe doing, it could be, and again, think when you are using sensory, when you are stimulating when you are just doing graded sensory stimulation, you don't want to overboard them, you don't want to overdo it, just like everybody. If I'm listening to a music from morning till now, I will get tired. Don't overdo it. Think about maybe in the morning after they had their wash with nurses or with family member. Okay, let them watch TV. Oh, get their radio on. In the afternoon, it could be maybe our junior physio, the intense physio, or the copper physio can go to their bedside. While doing some gentle exercises with them, you could go with lovely smells, depending on what they have, peps, or they use all these things to stimulate their sensations, make it better. It's not just rehabilitating them, is not just muscle strength. No, it goes beyond that. It's holistic management. Holistic. They can have pain. How do you manage their pain? Who do you need to use? All those things. Think about all these things. There might be weakness. Think about what we do, weight bearing. Yeah, you can still do electrical stimulation. Fine. Think about all these things. Educate family member. Family member, we have some questions. They are highly very emotive at this period. They will ask that if you don't know some questions, and again, with questions about these things, the recovery is not something you can say, yes, 100% they will recover. And it's not something you can say, no, they will not recover. Don't over promise them, or don't be over ambitious. Again, don't be pessimistic. Don't be pessimistic. Just work on what you can see. Don't forget you are treating what you are seeing. There's no definitive pattern, like stroke. Somebody have got MCA stroke, we know likely pattern. Somebody have got ACA stroke, we know likely pattern. But this one, the patterns might not, it's just what we are seeing is the pattern. If Mr. A had a TBI, what the presentation is their own pattern. If that makes sense to somebody. All these things are answering some of my questions I asked initially. Think about these things. And again, if you are the junior physios, if you don't have answers to some certain, even if you are senior physios and you don't have answers to some of their questions, say, no, I don't know. There's nothing wrong in saying I don't know. I'll consult my colleague and I'll get back to you. All these things are important. All right. So don't forget your ICM model. Let's say now they are not doing well. You are taking them to the gym in their acute hospital. Even in our acute hospital, that will be our hospital. In that acute hospital, that will be gym, not a patient gym now. Gym, that our acute facility. You can take patient there, we can do some aerobics, we can do some. But again, start doing you are now going into rehab proper now. Use ICM model. Look at different domains. The activity, their impairment, activity limitation, participation, everything. Not just impairment, pain. You are not, nobody is pain master. These are not, nobody is pain master. You are holistic. You are not pain champion. You are holistic. You treat everything. You treat human. Think about start using all those things. Yeah, so these are just abnormal reflexes. We have talked about this. And again, at some point, they will get discharged from the hospital. We can now, get them some referrals, send them to our outpatient facility. We use when they come to our outpatient facility, I will not be able to go in details because of time. So what are we looking at? Cognitive assessment, OT. While they were with us in the hospital, OT must be seeing them. They must be doing their cognitive assessment, doing functional assessment with them, washing and dressing, teach them out, kitchen. All these things are important. OTs are not, oh my God. So we need our OT to be able to do those things. Even in our patient facility, OT are still doing their cognitive assessment. If they need psychologists, some people can be emotional labor. Some people might need psychologists. Signpost them. It's not your domain. It's not your area. Don't do jobs you don't know. Signpost them to psychologists. You can still do some small things with them. Get family to encourage them as well. So they are now in our outpatient. We do strengthening, balance, cardio endurance, repetitive task training, whatever thing we want to do with them. And we are planning, we are thinking for them how we can join, we are jointly making plan on how they can reintegrate back to the environment. Know how not just impairment focus, how they can be more functional. If they need wheelchair, we get them wheelchair for the meantime. Even if it's going to be temporal, we want them to be mobile. We don't want them to always be on bed. We want them to establish transfer method with them. We want to do everything with them. If they need adaptation at home, we have done that. I expect ACUTE physios or OT to make arrangements. How are they going to be using toilet? I don't know. Do they need anything? Speak to the family member. Even if there is no fund, did you have that discussion with them first of all? Let's think about all of these things. And you are using standardized outcome measures in the acute hospital and outpatient, standardized. Like spasticity, for instance, like we mentioned the other time, you use stadio scales, you use modifier source scales, all those things. You use those scales and outpatient measure, depending on where they are or something, you use standardized approach, standardized method, these things. So I think I'm going to stop here today. I think we have had a nice time, even though we we were disturbed at some point. So can I get some questions before we go? Can I get some questions? Can I get comments? Does it make sense? Do we get any value from these things? Any value at all?
Yes, sir. Thank you, sir, for the wonderful presentation. I have two questions. One, I don't know about other places, but I know in my center, we don't have an ICP monitor. We go by the clinical features.
Sorry, you don't have what? Sorry.
Triad. ICP monitor.
Okay.
So when we are assessing the ICP, we use the clinical presentations of raised ICP and the Cushion Triad. Yeah. I don't know, all these things you're talking about, the values. So how do we know when is increased? Because what we usually do is maybe all those features, if they are not there, we know that the ICP is reduced. But though the values, they are very, very important, because when you're functioning and you find out that okay, if you're using a monitor, you will see it written on the monitor that is increased. But when you are now treating without monitor, all these things, because now to weigh the risk and the benefit, maybe a patient that has that is chesty, and the fear of the ICP increasing while you're working on the chest. I don't know, it's a real problem here for us in our center. It's a real problem, because one day I was asking one of the neurosurgeons why we don't have a ICP monitor of the machine. He said that it's because it's very expensive. But outside the country where I was trained, we use it. They place it and you see the reading, the value on the monitor. But it's not like that here. So another thing, another question is, a patient, maybe a child, because I work in the pediatric intensive care unit. Maybe the CO2 is high, and you have maybe the doctors, they have set the vents in order to reduce it, but it's still high. We as the physios, what can we do for the patient in order to reduce the CO2? What other things, apart from maybe all the chest physiotherapy we are doing, are there other things we can do to reduce the CO2? Then another thing, for a patient that has rib fracture, and that particular side, there is the patient is chesty there is a mucus accumulation. What do you do? Because some of all these equipment you are talking about, we don't have them here. So how do we help the patient? Because you can't do the percussion vibration for the patient. Are we going to go and functioning, like you said, will not really help. Positioning may not help, because there are particular positions you place a patient with raised ICP. So what do we do for the patients?
Yeah, thank you very much. And I'm happy that these kind of discussions are coming up, because initially what even brought some of this lecture in the first place is this kind of discussion. And I'm happy that we are beginning to realize that we are still not at the level we think we are in Nigeria. That is the reality. Not just physio, everybody, the doctors. I have spoken to a lot of Nigerian doctors, People that have practiced for donkey years in Nigeria, now they have found themselves in abroad. People will tell you they have done a lot of shit in the past. They will say it frankly, they have done a lot of shit. We are not at the level we think we are. And that is why some of these trainings, beyond what we are getting, the values and everything, some of these trainings are really important for us to keep discussing on those our physio group, on those our management, hospital management. Let's keep telling them that honestly, there is no excuse. There is no excuse for Nigeria at this point we are. There is no excuse for us. Is it money we will say we don't have? When we are we are just misplaying our priority up and down, spending money recklessly. Is it money we will say we don't have? You can't say it is money. Sometimes our situation is just sometimes management, sometimes knowledge issues, sometimes it's just a mix of everything. It's just a mix. Some people, I'm telling you, there are many things I did not know when I was in Nigeria. But when I came over, I began to feel like even handling oxygen too when I was in Nigeria. But here, so it's a mix of everything. But I think the first advice I will keep telling people, and I'm doing it as much as I can. And I want everybody to be doing it as much as they can as well. Is we should keep saying it. We are not doing enough yet. Outpatient is different from physio-wise now. Let's say physio, our own physio now. Outpatient is different from acute. We don't have those gadgets, those equipment to optimize patients. I have been in many situations here on call service in the middle of the night, acutely unwell patient that you just do something, just simple thing, and they are fine. But sometimes I have had this discussion many times with my friends, even in Nigeria, and those ones that are here. Just put this patient in the context of Nigerian situations. What is going to happen to them? I often have this discussion with them. Just this kind of patient, if you put it in context of Nigeria, what is going to happen? The chances they will die. Now, from MDT's perspective, you mentioned that we don't have ICP boats, monitor ICP, we don't have this. That shows some of our treatment. Yeah, we can use clinical science. Yeah, clinical science, but clinical science sometimes might not. Imagine patient that is being sedated, paralyzed, there is no ICP. How are we going to use clinical science? It's going to be difficult. It's going to be difficult. So clinical science again, yeah, great. We might be able to, but yeah, we might not be able to pick some little things. So again, it's just we going again, speaking with the neuro team. This is from physio perspective. This is what neuro team facing to everybody, talking with hospital management, everybody speaking to the government. This is what we need. This, rather than we focusing, fighting this one, fight this one is the boss, this one is not the boss. We are not still doing enough. Let's leave all this ego and focus on what we need to be doing. That is what I will say on that. Clinical science might not really pick some minor things, and what that means is that might be detrimental to patient care. And again, from the part of people treating, it might be like, I don't have clear values. I don't have values before me. Clinical science alone might not be enough. Imagine somebody that cannot even focalize, they cannot talk, they are disfigured, or they cannot talk, they are aphasic at the moment, they cannot do anything, they are even having facial issues or something like. Somebody can have terrible head injury, that their sensation, everything will be shut down. They cannot even report that they have headache, they cannot even report anything. They are just, how are we going to treat them? It's going to be difficult. It's going to be difficult. And again, some people, because of the injury they have, they are sympathetic, parasympathetic. The reading might not even be, the blood pressure, everything we are checking sometimes might not even be 100% appropriate, like 100% like very reliable. You might need to go with some other things. How are we going to do that? So what will likely be the end result of that patient? This is what everybody, I keep telling people, if we don't keep fight, anybody can be poorly at any point. Anybody can be poorly. But yeah, we can't control death, we can't control life or anything. But how are we sure that we are doing what we need to be doing 100%? So I don't know, but there's no excuse for us. What everybody just needs to do is let's keep shouting. Let's keep shouting. Let's let beyond, and I keep saying it again, even this our DPT, beyond outpatient things, we need more of acute things there. All these things need to be there. I keep saying it. I keep saying those things. Those things need to be there. Beyond Maitland techniques, VOP, all these things. Leave those things. We have learned those things in, what is it? In, what do we call it? In undergraduate. There's no point bringing up those things again. Let's learn something. Let's look at the gap. Something we have not been doing. They are doing somewhere else in the world. Those evidence-based, let's begin to do those things. Let's look beyond those things for now. All these things are important. So the other question is a child that is not what is the question again? That the CO2 is going up. The medical team, they have said they are looking at the vent parameters and everything. Yeah, what we just need to do from physio perspective is, number one, it is not in all cases we need to do things for this patient. If there is no clear indication for me to do things, I won't want to do things. The first of all, what I want to do is I want to look at their chest parameter, their respiratory parameter. Do I need to call me? Yes. If I don't have to call me, I will just leave them. It is just left with the MDT, the doctor, the medics, the neurosurgeon, everybody, peds, doctor, everybody, to figure out what is going on. It might not be physio related. It might just be maybe continuous bleeding. Maybe they need to pass a drain to their head. Maybe they need to decompress their skull, or maybe they need to do anything. They will keep looking at that. But in my own side, I will just keep monitoring their bench parameters, do everything I can, supporting them, giving advice. It could even be maybe they are not getting some parameters well on the vent. It could be me just coming in, look at the vent and discuss with them. Oh, why can't we do this? Giving them my own idea too. But sometimes we may not necessarily have to be involved directly. But if we need to involve, we need to again look at the risk and benefit. We need to weigh the two. And regarding the equipment about you cannot do percussion, you cannot do these things. What else do we do? Yeah, this is my greatest concern, honestly. However, if you are stuck, you can't do anything else. Like your percussion shaking, just like there are a lot of patient group that you cannot do heads down, because most of these things you see people teaching respiratories, postural drainage. There are a lot of patients like in acute hospital that you cannot try it. If you do heads down with them, they will die. They will die. So if you cannot do those manner technique, you cannot, what else? So there should be escalation plan. Escalation plan is some of these things we are discussing. Again, where are we on that in Nigeria? If we now have patients that need those things, what do? We will now be stuck. We will now be stuck. We will now be stuck. And suctioning alone is not enough. Suctioning alone is not enough. For a patient that is paralyzed, they cannot even cough when you suction them. Suctioning alone, you need to find something that will augment that cough for them. You need to support them. So where do we go from there? So this is my greatest worry. And this is why I will keep, tomorrow, I will keep saying it, let's get those things. And this is where my passion lies. We need to be able to be doing those things. Physio is really very important, especially in ITU, neuro. We need some great neuro skills beyond what we are doing currently. So let's begin to think about all of this. I don't know, am I able to answer your question, Ma, or you have some other things you want to add, Ma?
Yes, sir. Thank you, sir.
God will help us. So that is it's just so we just have to get our hands on deck and let's keep saying beyond pain. This one is not this. Physio has gone beyond all of those things. Physio has gone beyond that. So let's continue to top our skills. Let's continue to shout. Let's continue to get our government. Let's continue to get our leaders in this profession. We need to do what we need to be doing. So that is that about that. God will help us. Any other question, any contribution from anyone? Any contribution? Any contribution? Questions? All right. So we're going to be stopping here today. Thank you very much, everyone. Thanks for joining. So we'll catch up some other time. All right. Have a good afternoon.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, sir. Good night.